स्ट्रीम कर दे एक बार, देखो लाइव है। हाँ स्टार्ट स्ट्रीमिंग कर दे एक बार, देखो लाइव है तो मैं शुरू करूँ। हेलो, हाँ मैंने स्ट्रीम कर दिया, लाइव है अभी। ओके ओके ओके। Good evening, everyone. If I'm visible and audible, just give me a thumbs up, guys. Okay, so yes, Dr. Abhilash, Dr. Gayatri, Dr. One Mon 3. Okay, so I'm getting all these people. Okay, just give me a thumbs up, guys, if I'm properly visible and audible. Dr. Abhilash, Dr. Gayatri. Yeah, good evening. So just give me a thumbs up. Yeah, so I got a thumbs up from all of you. Let's start without wasting any time. Dr. Pratik also give you a thumbs up. Okay. Chalo, I think I'm visible and audible. So let me start with the session. This session is going to be our PYQ session, and we are discussing the questions that have come in the NEET PG as well as the INI-CET, right? So it's a proper revision that we are going to take in terms of the previous year's questions. They are not basically PYT, but directly PYQs that we are discussing over here. Okay, so these are all the previous year's questions that I'm discussing right now. All right. Okay, so I would like it to be a basically interactive session where I would prefer that you guys would answer. Let me start the questions one by one. So the first one over here is arrange, mark your answers. I'll try to see whatever answers you're giving, I'll discuss them. I always like it to be an interactive session. We'll hold it with the same way, right? So arrange the following anesthetic agents based on their potency. The 4 agents given are nitrous oxide, halothane, isoflurane, and methoxyflurane, and you have 4 options, right? So the first one you find methoxyflurane, halothane, iso, and nitrous. Then you have methoxyflurane, iso, halothane, and nitrous. And then you have methoxyflurane, nitrous, halothane, isoflurane, and halothane, iso, confusing options. For this, you need to know the answer, only then you will be correct. Otherwise, it is difficult. Questions like these, which come as a sequential arrangement, are not very easy questions. Here, it's not about one answer. You're supposed to know all of them in terms of sequence. Dr. Pratiksha says B. Dr. Tharani has given C. But those are both not the correct answers, right? B and C are not the correct answers, guys. So before we go forward, the point is this question is based on the concept of anesthesia, inhalation anesthetic agents, which is minimum alveolar concentration. All of us know it as minimum alveolar concentration, right? Based on that, they are asking you, we arrange the agents based on potency, right? So which is the most potent and which is the least potent. So for this answer, Dr. Positive Vibes says A and Dr. Sapna Shah says A. Correct. Absolutely correct. That's the answer. Right. Just remember one thing, M for methoxyflurane and M for most potent. Right. N for nitrous oxide and N for not potent, or in the sense it is the least potent. And based on that, you can just look, there's one option where it has given methoxyflurane is the most potent agent which you get. And here nitrous oxide, which you find is the least potent agent, right? So the correct answer here is option A. So just to go in short, discussing about the minimum alveolar concentration. So you just need to know what is minimum alveolar concentration. It is the minimum concentration of the inhalational in the alveoli, right? It's the minimum amount or the minimum concentration. So minimum amount of inhalational that a person is breathing in the alveoli, at which 50% of the patients do not respond to surgical or painful stimuli. Okay, that's the proper definition. We don't need to go too much into detail about it, but it is discussing as to how much amount that you need in the alveoli, which is going to produce anesthesia in 50% of the population, right? So 50% of the patient where it is going to prevent surgical or painful stimulus, right? So 50% of the patients, surgical or painful stimulus, it prevents. Okay. Right, in 50% of the patients, it prevents response to the surgical or the painful stimulus. This is your minimum alveolar concentration. Basically, it's the amount needed, right? Amount is always given by some number. If you talk of an amount, it's always by number. Here, it's supposed to be given by percent, right? So that percentage are the various values which are given. It's very difficult to remember the numbers. I agree with you. It's not easy. So you will find last here is methoxyfluorine where the number is 0.16. So you will find nitrous oxide with 104, desfluorine 6, sevofluorine 2, and fluorine 1.7. These numbers are not important, but what is important for us to know is the sequence. So remember, minimum alveolar concentration is basically telling you potency, and it is inversely proportional to potency. This is MCQ question. And what is the sequence that you need to know? Remember, M for methoxyfluorine, which is the most potent, right? After that, the next one is remember, old agents were the ones which are very, very potent. So methoxyfluorine, halothane. And after that, another old agent compared to the new ones is isoflurane, right? And then comes the two new agents, sevoflurane and desflurane. And the last that you get here is nitrous oxide, which is supposed to be the least potent or not potent. Another question based on the same thing is that when you're discussing minimum alveolar concentration, another concept comes is blood gas solubility or blood gas partition coefficient. So I discussed with you minimum alveolar concentration is one of the properties of the alveoli. But when the inhalational gut goes inside the bloodstream, it gets soluble in the blood. And that solubility in the blood is called as blood gas solubility, which is indicated again by numbers where there is no percentage, right? And again, a question from that has come. Okay, so I'll just go through that as well. So these are the various numbers which are blood gas coefficient or blood gas solubility numbers. Okay, which gas is soluble and which gas is not soluble. Right now, nitrous, when we're discussing minimum alveolar concentration, it told us that these agents which you see, these agents in terms of minimum alveolar concentration, they were less potent. These ones were less potent. Remember, inversely proportional I told you. And the agents which you see over here, they are relatively more potent. But when we speak of blood gas solubility, it is telling you which inhalational is soluble in blood or not. So you will find the initial drugs which are there over here, these ones which you find, these drugs are less soluble. And remember, if a drug is less soluble, it enters the brain faster because it is not soluble. So therefore, this determines the onset of action. So if it is less soluble, it has a faster onset of action. On the other hand, these agents which you see, they are more soluble. Since they are more soluble, their onset of action is slow, right? And methoxyfluorine has a value here around 15, right? So therefore, this is again a sequence which comes like this. So when you're discussing about blood gas solubility, this sequence also becomes important. I'm just discussing the exam point of view. Blood gas solubility. Remember, even this is inversely proportional to onset of action and recovery. Right? And here, let's take the same chart. I'm not changing it at all. I'm just changing the same thing. Methoxyfluorine, halothane, isoflurane, slight difference. And here also you will find till isoflurane and sevoflurane to be the same. Then nitrous oxide comes over here. Then comes desflurane and finally xenon. And this becomes your sequence for fast onset to slow onset. So methoxyfluorine, remember, inversely proportional. So methoxyfluorine becomes the slowest onset and recovery. Two important points I've discussed here. And xenon becomes the fastest onset and recovery. Remember, xenon is the most ideal anesthetic agent. Thumbs up, everyone. Is that okay? So I've discussed two important points over here. Let's go to the next question. So I discussed with you the minimum alveolar concentration as well as the blood gas solubility, the sequence. Achha, one more question was asked in the exam where they had asked you that desflurane and nitrous, their values are similar. They're almost similar. Okay. So if we go through the same chart that we went to, can you see this? Nitrous oxide and desflurane, they have blood gas solubility values almost similar. Thumbs up, guys. May I go forward? Okay. Next question. Okay. As I said, we are just discussing the PYQs. Next question. Which of the following local anesthetics causes hypertension? Is it cocaine? Is it lignocaine, bupivacaine, or prilocaine? Yes. As I said, I prefer to have answers from you and then go forward. Dr. Lucian says A. Dr. Sangeeta Reddy gives an answer. Dr. Poo 14. Okay. And so only till now I've got only one person giving me correct answer, and that is Dr. Lucian and Dr. Kavya. Okay, correct. That answer is cocaine. Remember cocaine. My branch is made up of cocaine, guys. Anesthesia. Cocaine. It was the first local anesthetic ever used. Remember this. Out of all the local anesthesia agents, this is the only vasoconstrictor. Remember, all others are vasodilators. So when we speak of local anesthesia drugs, remember, all local anesthetics are vasodilators, all of them. Remember, all of them are vasodilators, and that is why systemic absorption will increase, and therefore you get ADR. All of you have been interns and post-interns. You must have seen a vial of lignocaine plus adrenaline. Why have you seen adrenaline? So that it can cause vasoconstriction, as all local anesthesia drugs are vasodilators. So what will happen is the action on the nerve might decrease. So that is the reason why you want to add ADR, and that is why you have lignocaine plus ADR available, which is a better drug than lignocaine. But the problem is, because it's contraindicated in end arteries, we don't use it so much. So remember, lignocaine plus ADR is contraindicated in end arteries. Finger, toes, ear, nose, penis. Okay. Right? Lignocaine ADR, because all local anesthesia drugs are vasodilators, except for which one? Except for cocaine. Right? Except for cocaine. Remember, cocaine, CO, it is a vasoconstrictor. So because it's a vasoconstrictor, it might increase the heart rate and BP. That's another reason why cocaine is contraindicated with adrenaline. Right? Cocaine is a vasoconstrictor. So the answer here is A. Right? I think most of you were thinking about the fact that, bupivacaine being the most cardiotoxic. I think you thought about that. So all of you must have thought in this way. The ones who gave this answer, you are right. If you thought in this way that bupivacaine is the most cardiotoxic, I totally agree with you. Yes, it is the most cardiotoxic, right? And yes, when it is a cardiotoxic drug, you're sure when we discuss local anesthesia systemic toxicity, another question that comes in the exam is which organ system gets affected first. We all know it is the CNS that gets affected before the CVS. It's only in bupivacaine that you get the cardiac symptoms almost at the same time as CNS symptoms, and that is why it is called the most cardiotoxic, right? But when you're talking about the CVS symptoms, there were changes in heart rate, BP, but that's a complication. It's not talking about a complication here. They're just saying which of the following local anesthetic can cause a hypertension routinely, and for that the answer is going to be cocaine. Clear, everyone? So don't get confused on this point. The most common used local anesthesia drug is lignocaine. Okay, lignocaine. It's the most common. Bupivacaine is the most cardiotoxic. And remember, prilocaine. This drug is also important. It is used in two places. Last year's NEET PG question, intravenous regional anesthesia, and it is also used for the EMLA cream. Okay, since all of you are aware, that's why I'm just telling you. Remember this point also. Intravenous regional anesthesia, which is also called as Bayer's block. So prilocaine is used here in IVRA, Bayer's block, or EMLA cream. Okay, correct. Dr. Lucian says correct. Well prepared, guys. You guys are well prepared. Don't worry. I've got correct answers, but some of you have given me an answer with confused, slightly confused. So don't get confused, okay? And make mistakes over here. Making mistakes over here is perfectly okay, because every mistake that you make here is going to give you a correct question, correct answer in the exam if it comes, right? So make mistakes here, absolutely okay. Next question. Which of the following is required for a cannulation of a newborn, right? Again, as I said, these are all PYQs. It's not about a PYT. These are all previous year's questions. So a 22 gauge needle, right? IV cannula basically. A 24 gauge needle, 5 ml syringe, adhesive tape, normal saline. So options are in the first one, 1, 3, 4, and 5. Basically, here they're asking you if it is this one, and 2 and 4, which means here and here. So what are the options, guys? Anyone? Dr. Gayatri says B. Dr. Aki says A. Anyone else apart from that? Any other option? Dr. Sangeeta says B. Dr. Sapna says B. Correct. B is correct. Absolutely correct. Okay. When you speak about a newborn means just born baby. Remember, the baby is going to need the smallest IV cannula possible. 22 gauge is the one which is blue in color. 24 is the one which is yellow in color. This is a thin gauge. This is a small IV cannula. So therefore, you're going to use this, you're going to use this, you're going to use this, and you're going to use this. So the correct answer is B. 22 gauge normally will be used for a pediatric patient, can also be used for adults, right? For adults, when you're not getting a proper cannula, you can use it for them also, but not for a newborn, right? So B is the correct answer. Correct. Most of you have given me correct answer. B. Next question. Okay. So always remember, cannula, IV cannula is an important question. Guys, they keep on asking IV cannula again and again, and what are the things needed for that. Next question. Identify the incorrect statement in rapid sequence intubation. Okay, so pre-oxygenation with 100% oxygen is done for 3 minutes, right? A high volume, low pressure cuff is used. It is the method of choice in a cardiac arrest patient, and the induction agent and muscle relaxant are given simultaneously. Yes. So I'm getting answers. And I think, no, I don't think, I'm saying all of you, the ones who've answered, all of you are absolutely correct. Absolutely correct. Absolutely correct. When you speak about a rapid sequence intubation, it is also called as rapid sequence induction, right? This is basically done for a full stomach patient, right? And a full stomach patient, we are discussing about a full stomach patient that is coming, who's coming for an emergency surgery. I'm not discussing about a full stomach patient coming for CPR with cardiac arrest. I'm not saying you can't use it in cardiac arrest. But you get a full stomach patient coming for CPR with cardiac arrest. I'm not talking about that, but routinely this patient has come for an emergency surgery, right? You have a full stomach patient planned for a surgery, which cannot be, in which you cannot be postponed. The patient, you don't have time for, the NPO period, and you're supposed to intubate the patient immediately. So that is what is called a rapid sequence intubation, and that is why you're supposed to get a surgery done for this patient. So when you are doing a rapid sequence intubation, remember in this condition, bag mask ventilation is contraindicated. So next question comes over here. What are the conditions where bag mask ventilation is contraindicated, right? Another question is based on the same thing. Correct, Dr. Arpit? Correct. I was coming to the same point. So bag mask ventilation is contraindicated. So next question that is important in the exam, what are the questions where, what are the conditions where bag mask ventilation become contraindicated, right? So remember, any condition that can lead to risk of aspiration is considered as a contraindication for bag mask ventilation. Prominent mean a patient who is full stomach, right? Patient who's pregnant, pregnancy is always considered full stomach. Someone who is obese, right? A tumor, ascites, all that is considered full stomach. Patient with intestinal obstruction, volvulus, hiatus hernia, or delayed gastric emptying. All the causes of delayed gastric emptying can also come over here. Apart from that, congenital causes. A very important question asked about is congenital diaphragmatic hernia. Every second year they ask you this question. CDH, bag mask ventilation contraindicated. Tracheoesophageal fistula, meconium aspiration syndrome, pyloric stenosis, right? So these are all neonatal emergencies. All these conditions have bag mask ventilation contraindicated, which are risk of aspiration condition where you will not do a bag mask ventilation. Correct, guys. Correct. Absolutely correct, all of you. Correct. Well read. All of you are absolutely well read. Now let me talk about the anesthesia part. So full stomach patient comes for surgery, emergency surgery. You have to intubate him. And remember, in this patient, I can't do a bag mask ventilation. If I do bag mask, some oxygen will go to the lungs, some will go inside the stomach. It will further inflate the stomach and lead to regurgitation and aspiration. So therefore, in this patient, things have to be done very, very fast. Things have to be done fast. That's the first thing. It has to be done very fast. At the same time, you need to prevent hypoxia. Why you need to prevent hypoxia? I need to prevent hypoxia because bag mask ventilation is contraindicated and I need to intubate this patient. So because I have to do things fast, I have to prevent hypoxia. These are my three things. I have to do everything fast, I have to prevent hypoxia, and I have to intubate the patient. These are three things I'm supposed to do. And the fourth point, bag mask ventilation cannot be done. No IPPV for this patient. So what will you do? I will first pre-oxygenate the patient. So the first thing is give 100% oxygen for 3 to 5 minutes, right? This will have the lungs completely filled up with oxygen. It increases the FRC, right? Once that is done, patient is spontaneously breathing, or you give 8 vital capacity breaths. Once you are done with that, after that, when the lungs are filled with oxygen, you start giving the patient the induction agent and the muscle relaxant which are given simultaneously. Remember, the agent of choice here is ketamine. It maintains the airway reflexes, but yes, people use thiopentone and propofol also. But remember, drug of choice, full stomach patient, ketamine, MCQ question. And you give muscle relaxant immediately. And the fast acting, remember, fastest acting is succinylcholine, and where succinylcholine is contraindicated, rocuronium becomes the drug of choice. These two are the muscle relaxant of choice. And now remember, you had no IPPV, no bag mask ventilation. The problem is this: I have given a muscle relaxant, but I cannot do a bag mask ventilation, and that's why everything needs to be fast. And by then, I need to give cricoid pressure to the patient. The most important point here now is to give cricoid pressure. So cricoid pressure is something which compresses the cricoid cartilage. It's also called Sellick's maneuver. So you're going to give a cricoid pressure, which is given by an assistant, right? 30 Newton. And after that, it shuts off the esophagus. Then you do laryngoscopy, then you do intubation, right? After the cricoid pressure, you do the laryngoscopy, you intubate, confirm the position, and only then remove cricoid pressure. Only then remove cricoid pressure. This is called rapid sequence induction or rapid sequence intubation. Are you supposed to be using a cuff tube? Of course, because that is what prevents the aspiration. The kind of cuff tubes that we use nowadays, these are the what are called as high volume, low pressure cuff. Remember, there are two types of cuff: low volume, high pressure. So the low volume, high pressure cuff of endotracheal tube is like this. If this is the trachea, so this becomes your low volume, high pressure cuff. Low volume, high pressure cuff means all the pressure is at one point. So you will not want to use a cuff which has high pressure at one point. Nowadays, the tubes that we are using, the one which you're just seeing in front of you, in this tube, what happens is the cuff has high volume, but the pressure gets distributed along the tracheal wall. So this is the trachea and the tube inside. So the air that I'm filling inside, it gets distributed on the tracheal wall. This is what is called as a high volume, low pressure cuff. And yes, this is what is used. So talking about the answers now. Are you pre-oxygenating? Yes. Is the high volume, low pressure cuff used? Yes. Are the induction agent and muscle relaxant given? Yes. Is it the method of choice in a cardiac patient? No. This is the only one which is incorrect. Yes, you can use it, but ideally it is used for a patient who's full stomach coming for emergency surgery. Thumbs up, guys. Is it clear? All of you have given me a correct answer, but I gave an explanation for that as well, where I discussed the bag mask ventilation, congenital aphromatic hernia, important question. We discussed the Sellick's maneuver, the cricoid pressure. Okay, so remember this cricoid pressure and Sellick's maneuver is important question. Thumbs up, guys. Okay. Sir, why to prevent necrosis? Necrosis? You're talking of the cuff, na? So, okay, so what happens is, when you are using a high pressure, what will happen is, in a low volume, high pressure cuff, there's going to be tracheal pressure necrosis of the tracheal vessels, right? There's going to be a pressure necrosis of the tracheal vessel in the tracheal walls, and that pressure necrosis later on can lead to inflammation, fibrosis, and this can lead to a common complication that you must have heard, that you must have studied, but you know, which is called tracheal stenosis, on which questions are asked in the exam. So when you are using a high pressure, which is happening to the, what will happen is these blood vessels over here, if you're using a high pressure, there's going to be necrosis over there of the tracheal wall. It leads to inflammation, fibrosis, and ultimately tracheal stenosis. That's why you want the pressure to be distributed along the tracheal wall and not going out just at one point, which will cause more damage. Thumbs up. Is it clear? Okay, so here what will happen is all the pressure was at one point and now the pressure has got distributed. Dr. Sangeeta, fine. I got thumbs up from everyone else. Dr. Sangeeta says thank you. Thank you, Dr. Sangeeta. Okay. So you can ask me your doubts also, guys. Any questions, any doubts from anesthesia when it's coming to the question, we'll discuss that. Or iske baad bhi, if you want, you can ask me questions. Right? I'll try to solve them to the best of my knowledge. Okay. Next question. There is a case with an image given with marked EtCO2 value 40. What is it? Okay. Sometimes easy questions come in the exam. This was a very easy question where the answer is given in the question itself. Okay. Sometimes, guys, remember the answer is given, especially with image-based questions. Especially with image-based questions and subjects like anesthesia, you will find some questions where you will find the answer given in the image itself. Okay, so all of you know what is that EtCO2 value 40? It is capnography. All of you are aware of that, right? It is something to do with the breathing pattern, right? Respiratory rate. So here it's not talking about oxygen. All of you are correct. It's the value of capnography. Absolutely correct. Everyone has given a correct answer. Okay, simple. So this is a capnography which they have given. Based on that, there were another 2-3 questions that came in the recent years, right? So capnography, guys, the graph comes in such a way that whenever it's what is capnography? It's a monitor which can be placed right in the center of endotracheal tube, or it can be placed slightly away, which is called a mainstream or a side stream, right? Side stream. So now what will happen is whenever carbon dioxide comes out, it detects. Whenever oxygen goes inside, it does not detect. So therefore, whenever the carbon dioxide comes out, the graph goes up, and when the oxygen goes inside, the graph goes down. Whenever carbon dioxide comes up, the graph goes up, and when the carbon dioxide goes down, the graph goes down. So it happens like this. Okay, clear? One more question. Okay, one more question. I'm making one question here, which was again last year's question. I think I have the question in the end, but I want to ask here itself. This is your capnography graph. Wait, sorry. Just give me 2 minutes, guys. This is a capnography graph. I'm making 5 points here. Point A, point B, point C, point D, and point E. This is the question, right? What does the line CD represent? What does the line CD represent? Option A. Does it represent dead space gas? Dead space plus alveolar gas? Inspiration? And fourth is alveolar gas plus end-tidal carbon dioxide. Yes, give me an answer, guys. Oh, answering people already gave me. But I had given one more option. Na? Give me A, B, C, D. No, 1, 2, 3, 4. Let me make it A, B, C, D. A, B, C, and D. Okay. Right. All of you are right. Absolutely correct. All of you correct. Correct. This was last year's question. All of you remember? This question is there in the end, but I thought since I'm discussing it, I'll take the question here itself. Okay. So we made the question here only. Correct. All of you are right. So absolutely, guys, correct. Initially, when the gas comes out, whenever I was discussing this, whenever the gas comes out, initially what comes out is the dead space gas. And the dead space gas does not contain carbon dioxide. And that is why the line A to B would represent your baseline or the dead space. So this is your baseline or the dead space gas. And when the graph goes up, so actually the graph goes like this. The graph is slightly going up like this curve, then goes up and then comes this way. So this line B to C, this B to C is basically your dead space gas plus the alveolar gas mixed together. C to D is the alveolar gas, and this point D, this is called as EtCO2, end-tidal carbon dioxide. This is basically maximum alveolar carbon dioxide. Okay, and remember EtCO2 value is 35 to 45, which is almost the same as PCO2. Right, and then when the graph goes down, it means there is no carbon dioxide, it is inspiration happening. So D to E is inspiration. Clear? I think all of you have given me correct answer. This was an important question. We are done with this also. Next question. Okay, so we are done with that. A capnograph obtained from an intubated patient undergoing controlled ventilation is given below. Which of the following is the likely cause of the finding seen? Like you've got an image. Is it esophageal? Is it inspiration with cardiac oscillation, bronchospasm, or a spontaneous respiratory effort? Dr. Pratiksha is asking me a question. Sir, when normal patient is there, no RSI is done, what is done then after giving muscle relaxant anesthesia to patient for ventilation? Very good question, Dr. Pratiksha. Wait, I'll come, Dr. Pratiksha will answer that question in a while. And Dr. AP is asking me angle. Angle यार देखो यहाँ पे तुम्हारा alpha angle इधर है. Can you see this? I'll share this image with you in the PDF. ठीक है? Alpha and beta. These are the angles which are normally there. ठीक है? Here is what you call as the alpha angle. When the gas is changing from the airway, means the dead space to the completely alveolar gas. So alpha angle and beta angle. Right? These are two angles. Okay, guys? Clear? That is done. Then we had all of you have given me the correct answer regarding the next question, which is spontaneous respiratory effort, D. Right? Absolutely correct. एक question if okay with you guys, I would like to answer for one question out of Dr. Pratiksha. Sir, when normal patient is there, no RSI is done. What is then after giving muscle action anesthesia? Okay, now see what happens is, Dr. Pratiksha, you're asking me the conduct of anesthesia. So if, let me put it this way, if we get a patient, I'm talking of normal general anesthesia. I'm talking of normal general anesthesia. I'm discussing with you the conduct of anesthesia. What is the difference, right? So if when we are discussing of a normal patient, when there is no RSI done, what do you do for a normal patient? A normal patient comes into the OT, you attach the monitors. After the monitors, you put the pre-medication, which is given IV. You start IV fluids to the patient. After giving IV fluids, here there's a choice. You can pre-oxygenate. Sometimes you don't. Both is okay. But after that, you are going to give the induction agent, which is normally propofol. After that, muscle relaxant. After the muscle relaxant, you give IPPV for 3 to 4 minutes, because most of the muscle relaxants, their onset of action is 3 to 4 minutes, which you must have studied. Whether you speak of vecuronium, you speak of rocuronium, the onset of action of all of them are 3 to 4 minutes. After 3 to 4 minutes of positive pressure ventilation or bag mask ventilation, after that we intubate the patient, and after intubation and confirmation, then we go ahead with the case. But the difference that takes place in case the patient is full stomach, in a full stomach patient, right, what is the difference? This monitoring part remains the same, pre-medication remains the same. Yes, you can give pre-oxygenation, but instead of propofol and muscle relaxant, remember here you have 3 to 4 minutes, right? But here we don't have time. So here I'm going to use ketamine plus succinylcholine, which are very fast acting. Remember, succinylcholine is the fastest acting muscle relaxant. It is also the shortest acting muscle relaxant, right? Fastest means it works between 30 to 60 seconds, and the shortest means it works between 5 to 8 minutes duration of action. After giving ketamine, remember, no IPPV. You are just waiting for the, after succinylcholine, you're just waiting for the fasciculations to subside. After that, by this time, you're already given cricoid pressure. Till the time after the pre-oxygenation, this time we have already given cricoid pressure. This is different. You have not given a cricoid pressure over here. And after that, after this thing is done, then you intubate the patient. After intubation, confirm the position. Once you have confirmed the position, then remove cricoid pressure. Thumbs up. Is it clear? Dr. Sangeeta says safe apnea period. Correct. Okay. Then you remove cricoid pressure. Guys, okay? Sorry, I had to deviate because this was an important question. I thought it is going to be beneficial for all of you also. Okay? Okay? So that's the difference between a normal anesthesia and a full stomach patient. The only difference that starts is when you're giving the drug and what you're going to do after that. The difference is over there. Before that, pre-oxygenation, everything remains the same, right? But however, in a big corporate hospital and all, nowadays we don't pre-oxygenate. If the patient is fine, we tell the patient, don't worry, we are not pre-oxygenating you. We're just giving the, straight away we give the drugs. But ideally, you should pre-oxygenate all the patient. It gives you time to prevent the desaturation as maintained by doctors, as said by Dr. Sangeeta, right? When you pre-oxygenate a patient, you are never ever wrong. You are filling up the lungs with oxygen. Remember, another question has been asked based on pre-oxygenation. When you pre-oxygenate, you're filling the lungs with 100% oxygen. It causes denitrogenation. It increases the FRC. It increases the PaO2, and it prevents hypoxia for almost 10 minutes. A normal patient will desaturate in 4 minutes, and this pre-oxygenation for 10 minutes you get time. That is the meaning. Okay. Dr. Pratisha says, sir, Dr. Sangeeta says nitrogen washout. Very good. Dr. Pratisha says, sir, why IPPV is given till muscle relaxant is effective? Arey, to patient सांस कैसे लेगा? In the sense that even if you have pre-oxygenated, remember for 4 minutes, what will you do? Like normal patient, if you just give propofol and muscle relaxant, it's going to take 3 to 4 minutes to work. See, propofol will work very fast, but this is going to take, muscle relaxant will take 3 to 4 minutes. So intubation has to be done when the vocal cords are relaxed. All of you have worked in internship. It doesn't happen like in casualty when the vocal cords are moving and you put the tube inside. In anesthesia, you don't want those reflexes, those changes taking place. So you will want the vocal cords to get completely relaxed, to get completely paralyzed before you intubate. And that is why you will be holding the mask and ventilating for 3 to 4 minutes. when the effect of the drug takes place and then you intubate. Okay, Dr. Pratiksha? And you can't do the bag mask ventilation when you are giving succinylcholine cool. I mean, when you're the full stomach patient. That's the problem. And that's why this question of precoid pressure is so important. Let's go to the next question. Hopefully things are fine now. Okay. So we were discussing capnography. Sorry, I had to deviate because I wanted to clear that doubt out. Right. Capnography is what we're discussing. This was the image. All of you gave me a correct answer that the graph that you see here is spontaneous respiratory effort. Most of you even gave me the point. Yes, this is what is called curare notch. You know, guys, this is the time when we give muscle laxant to the patient. So esophageal intubation is this not the answer. Inspiration with cardiac oscillations will be something over here. So you will get like this. Inspiration with cardiac oscillations would be like this. Something in the inspiration. This happens in a patient like a pediatric patient. You get this kind of a graph in a pediatric patient or a patient with a thin chest wall. These are called cardiac oscillations where you get it during the inspiration, right? This is seen during inspiration. Now, this question which has come right now, this is curare notch. What is curare notch? A normal IPPV is going to be like this. This is a normal IPPV, okay? And this is what you can see over here. This is a normal IPPV. IPPV means positive pressure ventilation or controlled ventilation. But when someone is breathing spontaneously, it is like this. So whenever the graph goes up, that is expiration, graph goes down, inspiration. Same thing here, expiration, inspiration, but this is what is seen in spontaneous. So if I'm giving IPPV to a patient and in between he tries to breathe, this is where you get the graph which you just saw. I was giving IPPV, suddenly the patient started to breathe. And after a while, this patient will start breathing on his own. And that is why it is called curare notch. It means patient is out of muscle relaxant effect. Thumbs up, guys. Clear? Which means now it was initially IPPV and now it is progressing to a spontaneous breathing. This is the point where the patient is out of muscle relaxant effect. So therefore, if the surgery is over and then, this means the patient is out, don't repeat a muscle relaxant. But if the surgery is going on, in anesthesia, this is the point where we repeat a muscle relaxant in the patient because the duration of action of all drugs are different. In all patients are different, right? An old person will not need so much drug, but a young person will need more drug. So this is what helps you to repeat the muscle relaxant in a patient. It tells you when the patient is out of muscle relaxant effect, it means the patient has tried to breathe spontaneous, right? Whenever the graph goes down, remember it is inspiration. A graph going down normally is inspiration. So here when the graph has gone down, it means inspiration has taken place. A graph going down means inspiration has taken place. Clear? Okay, done. Next question. This question has been asked twice or thrice. Okay, different ways, but the same question has been asked. It's an important question. It was asked in INI-CET also and in NEET PG also. Right? ASA1 patient undergoing lap cholecystectomy. It was noticed that the EtCO2 decreased to 8, SpO2 became 90, BP dropped to 80/50, and the peak airway pressure was 18. The most probable diagnosis is embolism, bronchospasm, endobronchial, or pneumothorax. Yes, all of you, great, good. That means all of you, नहीं bronchospasm नहीं है, Dr. Fun mode. Bronchospasm नहीं है. See what is given. Okay, because all other people have marked correct answers. Everyone else has given a correct answer. It is embolism. So you will have to think first what is given. EtCO2 has decreased to 8. Let's go back right now. Forget about what we have studied before. We just saw the EtCO2 value normal is 35 to 45, which is the same as PCO2, right? And I am now saying the EtCO2 value has come down to 8. 8 means nothing. It has come to nothing, right? So normal value of EtCO2 was 35 to 45 and you have got it as 8. SpO2 normally should have been more than 95%. It has got decreased. The BP has got decreased, right? It should have been 120/80. Let me take it even under anesthesia, should have been 100/70. Now it has gone down. But one thing is normal, and that is peak airway pressure, right? The airway pressure is normal, right? This airway pressure is considered normal. So therefore, when the EtCO2 and SpO2 are decreasing, especially in a laparoscopic surgery, so here is the laparoscopy going on, right? So when a laparoscopy is going on and you are insufflating carbon dioxide gas inside, so what happens? The blood vessels are over here and suddenly the carbon dioxide goes inside the blood vessel, which is the biggest problem when you use that Veress needle and all that thing, you know, they can be damaged. And when you insufflate with carbon dioxide, suddenly that CO2 goes in the blood vessel, it can go inside the heart, it can block the chamber of the heart, and that is the problem of embolism. Why is embolism so dangerous? Because the embolus will go and block the heart. So this embolus will go inside, it is going to block the heart, and that is why the blood is not going to flow forward, right? Suddenly there is no metabolism seen and there is a sudden drop, as pointed out by Dr. Kalpana. Absolutely correct, right? Even Dr. Som Subra, correct. All of you have given that correct answer. That's the reason. So in this patient, CO2 embolism means sudden drop. Initially, the capnography graph is going to be normal, but as soon as the embolism takes place, the graph will become like this, right? Which means there is no carbon dioxide seen. What are the other causes? So you can get this graph. I'll discuss this again. In bronchospasm, what will happen is the peak airway pressure, because there's a spasm, guys, this is going to increase. Endobronchial, again, the peak pressure will increase. Pneumothorax, again, the peak pressure will increase. Even if we don't see the graph, all these three conditions are going to increase the pressures of the airway, right? All the three things, whether it is bronchospasm, endobronchial intubation, or pneumothorax. But if you look at the graph, bronchospasm means obstruction. So normal expiration should have been like this. But if there's bronchospasm, so what will happen? It will come slowly. It will come. The carbon dioxide is going to come out. It's going to come out regularly, but it's going to come out slowly. This is an obstruction. Endobronchial is also like an obstruction, but what has happened? Your tube has gone in one bronchus. Because it has gone in one bronchus, so therefore initially it will come out like this, and then it's going to come out like this. Means you will get a dip in between. It's like an obstruction, but it comes like this. It's going to come like this and like this. It is going to come like this, right? From one bronchus, because it has become endobronchial. In one bronchus, it goes like this, right? It's kind of an obstruction, but there is a dip that you see over here, and it's not an inspiration. It's just a dip from one bronchus and then bronchus, like how it's happening. In pneumothorax, the obstruction becomes reversed like this. This is what is seen in pneumothorax or emphysema. Again, it's an obstruction taking place, but you don't need to know these graphs. But I'm just telling you that is how the graphs look like. But for you, what is important is all of them are going to increase the pressures. But what is going to decrease here on pressure remaining normal is CO2 embolism. Now, what are the other causes where you're going to get a graph like that? Like in what condition you're going to get a graph like this, which has a sudden drop, right? Oh, all of you already gave me shark fin. Correct. That is shark fin. Good, yeah. Well prepared. As I showed you, all of you are good, well prepared for anesthesia. Shark fin. This is called shark fin appearance. Absolutely correct. I was discussing when do you get a graph where there is sudden fall. When there is a sudden fall of carbon dioxide, there can be 4 or 5 reasons. One that we just discussed is embolism. Other is esophageal intubation. Again, there is no carbon dioxide seen basically. Esophageal intubation. In case of a cardiac arrest, there's going to be no metabolism, no production of carbon dioxide. It becomes zero, right? If there is disconnection from the circuit, there's a disconnection of the instrument. Again, it's going to be like this, right? Or accidental extubation. In fact, one more point is there, which is complete obstruction of endotracheal tube. Complete obstruction of endotracheal tube by a mucus plug, by blood or anything. Okay, that is again going to produce no carbon dioxide coming out. Okay? Even in that case, you'll get a graph like this. Correct. All of you have given me correct answers. Circuit break. Good, guys. All of you have given me all correct answers. So I think you're good with capnography. Capnography is an important question, guys. Yeah? No one can predict what will be asked, but all these is are important questions. I think all of you are well prepared. Right? Next question. Which of the following agent can be used as a sole agent for induction and intubation? Sevoflurane, isoflurane, halothane, desflurane. Simple question. Yes. I think yes, or I think all of you have given me correct answers, right? No one is wrong. Absolutely correct. Absolutely. The answer is sevoflurane. Okay, absolutely correct. All of you are correct. The answer is sevoflurane. So when you discuss sevoflurane, remember one point, the 2 point, sevoflurane is an agent which is sweet to smell. Okay, sevoflurane is S, it is sweet to smell. And remember, sweet to smell means it is also good for the respiratory system. It's a bronchodilator, right? On the other hand, remember, even halothane is sweet smelling and is a bronchodilator. But because sevoflurane is a newer drug, that is the reason why it is a drug of choice in a pediatric patient, and that's why it's a drug of choice for a respiratory patient, right? But apart from that, remember, sweet smell, bronchodilator means it is going to relax the bronchus. It's not constricting the bronchus. Why? Desflurane is a drug which is maximum bronchial irritant. It's pungent, maximum pungent, and maximum bronchial irritant, right? On the other hand, halothane and sevoflurane are bronchodilators, so they're going to relax. So they also work as good relaxants. So sevoflurane works as a very good skeletal muscle relaxant. On the other hand, you must be knowing that even halothane has a good property. It has the maximum uterine muscle relaxant property. In fact, that's one of the places where it is drug of choice for manual removal of placenta as well. And now, because sevoflurane is also a skeletal muscle relaxant, so therefore the first thing is that because it has a sweet smell, it's a drug of choice for pediatric induction or inhalational induction. At the same time, it works as a skeletal muscle relaxant. It's one of the best. It has the maximum skeletal muscle relaxant effect. So therefore, when you want to use an agent for induction because of the sweet smell, right? Inhalation induction drug of choice. And for intubation, I just told you I need vocal cords to be paralyzed. So this is going to cause muscle relaxation. Let's go back. Let's go back. I'll use the same example to explain this point. Do you remember I told you right now when I was explaining a patient comes for normal patient coming for anesthesia, and let's take the normal patient is a pediatric patient. Now the pediatric patient does not let you take an IV cannula. Okay, you don't have an IV cannula. So in this case, what will I do for the patient? In this case, can I give pre-medication? Everything seems to be different. Normally we take an IV cannula, I'm not denying, but normally in a pediatric patient, what you can do is you can just hold the mask on a pediatric patient, and what drug we are going to use is sevoflurane. Once you use sevoflurane, remember sevoflurane is also working as an induction agent and it is a muscle relaxant. It's doing both the work at the same time. So it can be used as a sole agent for intubation as well as induction. Thumbs up. Audio is low. All of you, audio is very low or what? Am I audible? Mr. Peace said थोड़ा सा audio low है. Odor तक तो ठीक था. Is my audio okay, all of you? Dr. Pratiksha says it's fine. Mr. Peace, Dr. Gayatri says it's fine. Dr. Pooja, everyone says okay. चलो यार, fine. And Dr. Peace, I think आप फिर से ना, you just go ahead. I think do वो क्या बोलते हैं उसको? What do you guys call it? अरे फिर से बटन प्रेस करते हैं ना, री ज्वाइन अगेन, रिफ्रेश. वर्ड भी नहीं याद आता है, इतना एनेस्थीसिया में घुस गया हूं कि वर्ड ही नहीं याद आ रहा है. रिफ्रेश, ओके, रीजॉइन. हाँ, रीजॉइन या रिफ्रेश. ओके, होपफुली दिस पॉइंट इज क्लियर रिगार्डिंग sevoflurane, everyone. Correct. So this was about sevoflurane. So this sevoflurane is a sole agent that can be used for induction as well as intubation, right? Okay, clear. Then when I'm discussing, let me discuss one more point here, exam point of view. And according to me, I know all of you might think differently and some people might not agree with me. Some books will also not agree with me, but from whatever I have read and from whatever I feel, for all the inhalational agents, drug of choice, right? When you speak of a patient, right, in a cardiac patient, let's take one by one the systems and then we'll discuss in which system, which is the drug of choice. So if you take a cardiac patient, here the drug of choice is isoflurane. So someone had mentioned here regarding coronary steel phenomena, but it's very rarely seen. Isoflurane में दिखता है, but कम दिखता है. I agree with you. But still, the most important point about isoflurane is that it maintains cardiac output. Okay, compared to other agents, it maintains cardiac output. And that is why ideally for CVS, the drug of choice is isoflurane, and I will prefer it more over sevoflurane. But in some books it has given, or some platforms you will do find that, some platforms have said sevoflurane over isoflurane, but I beg to disagree slightly, because no book gives you this is the drug of choice. They just say individual patients. According to me, isoflurane maintains cardiac output. It is the best drug to be used in a cardiac patient. Yes, there is a theoretical possibility of the coronary steal phenomena, but that is more common because it is a coronary vasodilator. So this is more commonly seen with drugs like dipyridamole and hydralazine, right? Where the drug starts to go from the ischemic to the normal area, and because of which the patient lands in myocardial ischemia during the procedure or during the surgery, right? But it's very rare. They say there are hardly any coronary steal seen with isoflurane, but yes, theoretical possibility is there. अभी मैं इसकी बात कर रहा हूँ, inhalational agents only. So according to me, isoflurane, but yes, you can use sevo and des also in a cardiac patient, but ideally you should be using iso according to me. Not to be used are halothane and enflurane. When you speak of CNS, or let's take kidney patient, when you take a kidney patient, when you take obese patient, in these patients, I want a drug which is non-nephrotoxic, which goes very fast, comes out very fast, and the answer here is desflurane. The same thing holds true in a patient of shock. Desflurane increases the heart rate and BP slightly, so it's a drug of choice in a patient of shock. This is where desflurane is preferred. Kidney patient, obese patient, shock patients. Now again a confusion comes, daycare surgery. For daycare surgery, again desflurane being the fastest should be used, but here some books have said sevoflurane is as good as desflurane for daycare surgery. Now individually it depends who has chosen which book. But daycare surgery, sevo and des both can be used, but a lot of people prefer sevo. But desflurane, but desflurane is the faster acting, no doubt about it. Okay, no doubt about it. So daycare. So we have done with the CVS, we are done with the kidney patient, daycare patient. After that, most of the systems you will find the drug of choice is sevoflurane. Beyond this, so if you take at the liver patient, a liver patient, non-hepatotoxic drug is sevoflurane. Sevo is non-hepatotoxic. It is preferred over isoflurane and desflurane, right? But isoflurane, remember I told you it's a coronary vasodilator. It maintains cardiac output. So when it comes to liver transplant, it maintains the hepatic blood flow. So in a liver transplant, you will find isoflurane to be the drug of choice, right? But otherwise for a liver patient, sevoflurane is to be better than iso and des, right? CNS. Again, CNS, some people say sevoflurane, some people say isoflurane. I would prefer, it depends both. Sevo and iso both can be used. It depends on what, right? What does the individual properties? That sevoflurane, it produces the least increase in the cerebral blood flow, while isoflurane has the least increase in intracranial pressure. Both of them can be used, but yes, sevoflurane being a newer agent, people prefer to use sevoflurane over isoflurane. So as you can see, daycare surgery, liver, CNS, and beyond that, respiratory patient. So if you have a respiratory patient, right, which I just discussed with you, a respiratory patient, bronchial asthma, pediatric patient, and inhalational induction. In these cases, sevoflurane is preferred over halothane. Thumbs up, guys. Okay, that according to me is the best thing for all these systems, according to me, from the inhalational's point of view. Thumbs up. Okay, according to me. As I said, there are always going to be differences. Some people might not agree with me also, but I give you my reasons. Dr. Pitt sir for desflurane TEC6. Yes. वो भी important question है. चलो, वो मैं सोचा था बाद में. Before I want to discuss that question in the end when there was some other question there, but because you've asked me, correct. Desflurane, remember, has a special vaporizer which is electrically heated. Okay, remember this point. When you're speaking of desflurane, it has a special vaporizer, electrically heated. जिसको TEC6, it is called TEC6. Okay, correctly said. Okay, TEC6 vaporizer. Out of the others have a simpler structure, but this is the one which is different. I was going to discuss all this in the end, even the colors, but it's okay. Since you asked, just point it out, I'll discuss it over here. Okay, next question. During resuscitation, the patient received intralipid 20%. Okay, so what could be the most probable cause of cardiac arrest? Dr. Sombhadra Das says blue. Yes, blue. But color मैं बाद में लूँगा. I'll take it later on. I'll take the colors later on. Okay, so Dr. Arpit, Dr. Poo, Dr. Sangeeta, Dr. Som Shubhra and नहीं बाकी लोग तो दे. डॉक्टर दास आपका आंसर थोड़ा सा अलग है. लास्ट एस्पेक्सिया नहीं होगा ना. इंट्रालिपिड. What is intralipid? Intralipid is what lipid you must have seen in the ICU. All of you worked in the ICU. This is one bag of that intralipid that is used for total parenteral nutrition in an ICU patient. The one who's not eating food. When we give total parenteral nutrition, this is what is called as intralipid. The same thing is used to treat local anesthesia systemic toxicity, especially with bupivacaine. Because normally bupivacaine, as I told you again, remember, like right now, a while back I told you, local anesthesia systemic toxicity, CNS symptoms take place before serious symptoms for all the agents except bupivacaine. In bupivacaine, I told you it's the most cardiotoxic. Here you will find serious symptoms at the same time as CNS. And what are the serious symptoms basically, guys? They are arrhythmias, and CNS symptom, the most common is convulsions, right? So other patients, you are going to get convulsions before arrhythmias. But in case if it's a bupivacaine toxicity, you're going to get arrhythmias before convulsions. Now, because it is affecting the heart before, we give intralipid because it is found that intralipid will make these complexes with the with this drug, because the drug has gone intravascular. Na? What's the meaning of local anesthesia systemic toxicity? It means the bupivacaine, this bupivacaine, which was supposed to be working in a local area, I was supposed to give it in the local area, is not gone into the local area. This bupivacaine has gone intravenous into the systemic circulation or intra-arterial, but not intra-arterial, but basically systemic circulation mein chala gaya. It's been absorbed in the systemic circulation. Because it has gone in the systemic circulation, it's going to affect the CVS and the CNS. Otherwise, bupivacaine was supposed to act only locally. But now, because my drug has gone in the systemic circulation, I am getting the cardiac effects and the CNS effects. So when you give intralipid, it will go and bind to this bupivacaine. It will form complexes and take it away from the body. And that is the treatment of this. So local anesthesia systemic toxicity, especially with bupivacaine, when you speak of the treatment. So remember, you have to treat the convulsions, right? So you are supposed to use anticonvulsants and antiarrhythmics, no doubt about it. Anticonvulsants, antiarrhythmics, but this is one of the most important things, 20% intralipid. Another point on which question has been asked, and that is, remember, you are supposed to give small doses of adrenaline. Why is adrenaline given? And you will ask me, sir, why ADR? So what happens is, in case your CVS has gone, remember the CNS symptoms are reversible, but CVS symptoms may be irreversible. If the heart, it stops, it will stop. And that is why you don't want the heart to stop. The small doses of ADR keeps the heart beating. And that is why it's not a proper adrenaline that you use, but very small doses of adrenaline are given to keep the heart beating so that the heart does not stop. Okay. So these two are the new treatments which are seen for the local anesthesia systemic toxicity with bupivacaine, 20% intralipid and small doses of adrenaline. Okay. So if you will find here also written. Okay. This is the treatment for that. Lipid emulsion hai, and then ADR is also there. Small doses of ADR. Low dose epinephrine is preferred. Can you see this? Low dose epinephrine is preferred, right, with titration, and we don't use vasopressin. This is an important point. Okay, low dose epinephrine. Clear? That's the treatment of local anesthesia systemic toxicity. Okay, next question. Now, this question can become, okay, two ways. First, I'll change it. The immediate complication to me. First, the most common complication seen with this procedure. The most common complication seen with this procedure. So you first have to see what is the procedure. I hope you're able to see. Yes, you can see the procedure. Right? So Dr. Gayatri, Dr. Pankaj, Dr. Arpit, correct. Dr. Pooja, correct. Okay? Dr. Sapna, all of you right. This is the most common. Absolutely correct. Because what is the procedure taking place? You are putting a line where you can see blue color. What is blue color? Blue color is a vein. So you are putting something in the vein. What goes in the vein? It's a central vein. You know, it's not an IV cannula in the hand. So basically you're inserting a central line or a central venous catheter. And which place is this? You're inserting it over here. It's a subclavian. So basically the procedure is a subclavian central line. Okay, correct. नहीं block नहीं हुआ ना, central line हुआ. That's what I'm trying to say. Don't get confused. This is a central line. And then the next question comes, a specific complication rather than most common. Let me cancel the question. I'll keep the option same now. And now my question is a specific complication seen with the following procedure. It's not a block. It's not a block, guys. ये block नहीं है. Pneumo. अरे all of you are giving answer D and pneumo. पर pneumo तो option नहीं दिया. This was INI-CET question 2023. एम्पाइमा कैसे होएगा? What is एम्पाइमा? इन्फेक्शन को उसको टाइम चाहिए होगा ना to develop एम्पाइमा. It's going to take time. Am I right? Yes, the answer is B, chylothorax. What is a specific complication? Remember, the thoracic duct runs on the left side. This was an INI-CET question. So when the thoracic duct is running over here, all of you must have seen in complications which we read but we don't remember, is that along with pneumothorax, hemothorax, another option given always is chylothorax. If you read any book, any source that you have read before, everywhere they would be giving, no doubt. I'm saying pneumothorax is most common. I am not denying. But if this is specific complication, because this is a left-sided subclavian central line incision, you will not get thoracic duct on the right side. It happens on the left side. So therefore, on the left side, if you have punctured or if you have cut the thoracic duct, you might get the chylothorax as a complication. So that's the question which was asked. I agree with you. Pneumothorax more common, right? Most common. Hemothorax is also there. And of course, you get chylothorax. So you must have read this also. All the three are there. But remember, chylothorax happens only on the left side, and these can happen on both the sides. Okay. Thrombophlebitis is out and empyema is also out. So when you're discussing these complications, especially of the central line, first of all, remember central line, the most common spaces used are internal jugular, right? Internal jugular and subclavian are the most common. These are the two areas. Of course, there is femoral, and femoral, the most common thing done from a femoral is dialysis. This is inserted for a dialysis, right? And you will see basilic and cephalic, which is called a peripherally inserted central catheter. So here you get the basilic and the cephalic, right? And these two are basically used for what? Chemotherapy, total parenteral nutrition, all that is given from here. These are basically chemotherapy ports, right? Chemotherapy. Dr. AP says, sir, repeat again. What? कौन सा? Thoracic duct वाला कि इधर वाला? अच्छा, let me take this completely. Wait. Let me take this completely. Wait. Let me put the central line and I'll discuss with you. First of all, central line. Central line is inserted in any major vein of the body. Internal jugular vein, subclavian, ठीक है? Femoral, basilic, and cephalic. Normally, the most common that you have seen is internal jugular and subclavian. Okay, femoral is the one which normally you must have seen that it goes in for a dialysis. Basilic and cephalic are normally used for chemotherapy as chemotherapy ports. Right? Apart from that, mostly Dr. Xavier says mostly femoral. हाँ, femoral is for dialysis, na basically. नहीं, most common femoral नहीं होता है. Most common internal jugular या subclavian. The most common is that. Okay, but basilic and cephalic, chemotherapy. So apart from this, what you see, what are the common uses of a central line? It tells you the central venous pressure, CVP. All of you would have heard of something called as CVP. A normal CVP is normally 8 to 10 centimeter of water, right? It tells you basically the fluid status of the patient, right? How's the fluid status or the volume status of the patient? Apart from that, it gives you a port, a direct connection to the venous circulation. Because it's a connection to the venous circulation, I can give medications from there. I can give fluids from there. I can give blood from there. I can give this chemotherapy. I can give total parenteral nutrition from there. I can also insert pacemaker from there. It makes life of intern easy, blood collection, right? Apart from that, for all the major surgeries where there is major fluid shift, ICU patients, we insert central line. Correct? Then complications. The most common, let's divide it into 3 things. The most common complications, see, wherever there is a vein, there's an artery, there's a nerve. So when you're trying to insert in the vein, the first thing can go away is the artery, right? So therefore, the most common complication ideally is an arterial puncture. It's not pneumothorax. Most of the times you are going to get an arterial puncture because the artery lies just next to it instead of the veins going in the artery, which can cause a hematoma. Next point, the tip of central line, it goes at the junction of superior vena cava and right atrium over here. See, this is the place where there is the tip of central line. So tip of central line is at the junction of superior vena cava and the right atrium. That's the tip. So it's going inside the heart also, right? So therefore, the tip of the central line is at the junction of superior vena cava and the right atrium. All right. So it can cause a cardiac rupture, and it's also known to cause arrhythmias. In fact, arrhythmias is one of the signs that you've placed it correctly. When we put it clinically, we say that if the arrhythmias have come, it means you have placed it correctly. Apart from that, now let's talk about the respiratory. I mean, what can happen to the lungs? Pneumothorax, hemothorax, chylothorax. Remember chylothorax on the left side? There can be bleeding, there can be infections, and if you open it to air, chances of embolism are also there. Though it is used for treatment of embolism, it can also cause embolism. These are the complications. Okay, clear everyone? So I discussed the central line, very good, the uses and the complications also. Any other doubt? Okay, Dr. AP? Hopefully central line ho gaya. All fine. And thrombophlebitis and all these are not complications. Thrombophlebitis will not happen in this vein. Empyema will not happen over here. So it does not happen with this like this. Okay. Clear? Next question. Again, this was INI-CET question. Normally, I don't expect this to be asked. I don't expect, but because we're discussing previous year's questions directly, these are those questions which comes once in a while, but still we should discuss. The common questions, all of you know, that capnography and all. These are the questions we miss out. This was one question asked in INI-CET. Metabolic equivalent of 1500 ml of oxygen consumption per minute for a healthy 70. You don't understand which branch it has come from. You know, that's how anesthesia questions are tricky. Dr. Xavier says, but sir, mostly we do it ultrasound guided. How the complications are there? It's ultrasound guided, but still complications can be there. Na exam mein to ye puchte hain. Dr. Xavier, normally what happens is you're right. You don't get complications now. Ultrasound has made it safe, but yes, there can be complications. Na? That's what is asked in the exam. You are absolutely correct, Dr. Xavier. These are all ultrasound guided now. All right, so Dr. Xavier is correct. Dr. Arpit says about the answer 6. Yes, correct, Dr. Arpit. Absolutely correct. Absolutely correct. Okay. So in this question, you don't have to do anything. It's basically a maths question which came in the exam. Okay, it came as a maths question. So what has happened? They've given there's a 70 kg adult male. This male has a basal oxygen consumption 250 ml per minute. Okay, matlab if you take basic maths. Dr. Xavier says, okay, sir, only theoretical. Mostly theoretical, but we have seen it practical also. See, when people are doing it for the first time, you never know where it gets ruptured. Okay, when some junior, even from senior also, if you get an obese patient, you can't identify where the artery is there, where the vein is there. Many times, you know, when the vein is, when you see an ultrasound, so you can see the vein like this. Initially, it opens and then it closes, you know, because the vein collapses also, na? Sorry, artery we will see like this. Lekin vein is seen like this. An artery will go up and down, up and down. So many times when you're putting the needle directly, here is the vein, but you will find an artery also somewhere, and by mistake if you go there then, so that is always a possibility, it's avoided. Okay, so ultrasound also helps, but yes, you should be aware of the complications which can take place. Dr. Arpit says how to calculate. Yes, that was I'm coming. In 1 minute, 250 ml is being used by this patient, right? Right. What is the metabolic equivalent of 1500 ml? 1500 ml, how much is the metabolic equivalent? So there is 250 ml, and basically how much is 1500 ml going to be? So basically the answer would become 1500 divided by 250, this and this, and the answer becomes 6. The correct answer is 6. These are the metabolic equivalents correctly said by Dr. Arpit. Okay, absolutely correct. This was a simple maths question to calculate what is the metabolic equivalent. But what is the significance of this? Metabolic equivalent normally is a 3, you must have studied all this in physiology, 3.5 ml per kg per minute. Okay, metabolic equivalent, right? This is your metabolic equivalent. Here it was just asked to calculate how much are the METs. What is this important for? Remember, in anesthesia, this is a very important predictor of the cardiac function. It tells you the cardiac function or the cardiac reserve of a patient. For example, if I get a patient tomorrow in the OT and the patient says, sir, I am doing cycling for 30 minutes continuously. I was dancing for 30 minutes and tomorrow is my surgery. Let it be a laparoscopic cholecystectomy. Will you be scared in that case? I'll say, no, I'm fine. Your cardiac reserve is good, respiratory reserve is good. This is called METs more than 10. Metabolic equivalents are more than 10. He can do strenuous activity, right? This is fine. Then you have got divisions less than that, around 7. You will say around 4 to 7. When someone can climb a few stairs, basically we take it as climbing one flight of stairs. One flight means one floor. One floor, if someone can climb, one floor, if someone can climb without breathlessness, without stopping, it is called METs around 4. And that is the basic thing that anesthesia guys, all of us ask during the pre-anesthetic checkup. If a patient is unable to climb one floor without stopping, without being breathless, it means the cardiac function is poor, or cardiorespiratory, I'll rather put it, cardiorespiratory reserve of this patient is poor. And in that case, this patient needs to be further investigated, right, or further optimized. And therefore, this metabolic equivalent helps us, METs, helps us to see that anything above 4, the patient is fit for general anesthesia. So someone who can run, someone who can climb a floor, someone who can do strenuous activity, sports, highly strenuous activity is fit to undergo GA. Here we say the respiratory reserve is good. Do you need the classification for exam? Normally, no. I don't think so you need the classification for exam. Normally, a question from this has never been asked. But I'm just telling the significance why this is there, okay? More than 4 is fit for GA. Less than 4 means the person can't even walk properly or climb one floor, is getting breathless. This is what happens in all the people who are obese, obstructive sleep apnea, suffering from some disorder, cardiac abnormality. These are the people who need to get further investigated, right? I'm not confusing you with ASA grading now. This is a separate grading. It's for a cardio reserve, cardiorespiratory reserve. So this was a old, not old, but 2 years back INI-CET question. So here you just had to calculate the METs. It was a simple maths question. That's it. And I told you the significance for it. You don't have to go too much into detail. I told you new information, you should not get in too much before the exam. Just have a slight idea, but new information, don't read too much. It was a PYQ, hence we discussed it out. Okay. But this is an important question. Measurement of a nasogastric tube. This is where we make mistakes. You make mistake in the previous question, that is understandable. You can't make a mistake here. All of you have been doing it day in and day out. Okay. Is this the same as Dyspnea grading? No, it is slightly different, Dr. Xavier. The Dyspnea grading is called NYHA class. Okay, NYHA. Right? This is our metabolic equivalent. That is NYHA that you are talking about. Okay, there are 2-3 classifications. All right. All right. So what is the answer? All of you have done it every day of internship and post-internship. You must have done it day in and day out. Day in and day out. Okay. Don't make mistakes here. And as I find, hardly only one answer is correct. Okay. See, nasogastric tube का मतलब होता है Rayleigh tube. Rayleigh tube normally, imagine how you people have put in the wards. You tell the patient, open the mouth. Open the mouth. Have you done that? Remember on wards, what have you done? You put it in the nose, you told the patient, open the mouth, now drink water, and it goes inside. Okay? So therefore, is angle of the mouth the first point? No. Right? Tip of the nose to below the ear till the manubrium. Manubrium means here. Your Rayleigh tube is not supposed to be here. Your Rayleigh tube is supposed to go inside the stomach. Correct. The correct answer, guys, initially only one, but now 2 or 3 of you have given. Answer is C. Correct. Answer is C. If you will look at this, this is how you calculate, right? Ideally, your Rayleigh tube has to go inside the stomach, right? Your umbilicus is somewhere here. So basically, you're going to have it from the tip of the nose to the ear to the manubrium and to the midpoint in between the umbilicus and the manubrium. Thumbs up, guys. Is that okay? This is the ideal size of the Rayleigh tube, especially for a pediatric patient, but adults may be aise karte. Normally, this is what we do for adults also. Okay, it's the same thing. The mouth, we ask the patient to sip water so that when he swallows, the Rayleigh tube from here goes here directly inside. Otherwise, all of you know how much problematic it is. The first time, all of you guys will never forget, putting a Foley's catheter was easy, but putting a Rayleigh tube was difficult. Am I right? All of us here, I'm not talking of all of you, even for me, putting a Foley's catheter was very simple. You just had to put jellies and the passage was clear. It went inside. But Rayleigh tube, the problem is it can go even inside the lungs, right? So all of you would remember inserting a nasogastric tube, a Rayleigh tube was much more difficult than putting a Foley's catheter, right? And so many times, in spite of experience, even now, I can't be sure that, definitely I'm going to put it inside the esophagus and stomach. Even now, no one can always be confident, but yes, you need to know the exact size which has been asked in the exam. So tip of the nose to the ear lobule, or in fact the tragus also, you can write it as tragus as well. It can be that, right? Tip of the nose to the tragus, to the midpoint between the manubrium, sternum and the umbilicus. Okay? Clear? This is an important question. Nasogastric tube. Identify the equipment used. What is the equipment that you can see? Image based. Yes, guys. Check by the syringe of air and stethoscope. Correct. Okay, one more clinical point. But yes, you're checking by stethoscope. If you don't want to use stethoscope, guys, I'll tell you what. When you push with air, just keep your finger over here. You can feel that air even on your fingers, and we do that many times in the OT as well. Okay, you will see anesthesia, guys, all the people from anesthesia, all the anesthesiologists to be doing this. Okay, try that. Air, sound, or gastric aspirate. So you can just keep your fingers and you can feel that pop over your fingers also. What you hear on your ears, you can get it here as well. Okay, so now next is whoosh sound on stethoscope. Correct. All of you are absolutely correct. Okay. Next time you try it, next time you guys try it, you put a Rayleigh tube, no doubt use a stethoscope to confirm. I'm not saying stethoscope is the best point, but otherwise you could just put your finger and you feel that same on your fingers as well. Try to do it. Okay. Practical point. Okay, all of you have given me a correct answer. This is a high flow nasal cannula. How did you identify? Of course, here it looks like a nasal prongs. Here it looks like a normal nasal prong only. But yes, it is different. The reason why I could identify and all of you could identify was the presence of this point, which is the humidifier. This humidifier is how you identify this image to be a high flow nasal cannula. Okay. High flow nasal cannula. This humidifier. Okay. This is the humidifier that you see. This helps you. So this high flow nasal cannula helps the patient to get warm and humidified oxygen. Right? And remember, from the high flow nasal cannula, you can give up to 100% oxygen. And correctly mentioned by Dr. Doc Saab. तुम लोग के नाम भी अजीब होते हैं, तुम लोग अजीब अजीब नाम रखते हो, प्रोनाउंस करने में भी डिफिकल्ट होता है. Doc Saab. He's correctly mentioned 40 to 60 liters per minute. Absolutely correct. So it provides up to 100% at 40 to 60 liters per minute. I was thinking, what should I keep my name? All of you have got pen names, when no one will identify you, when I should keep some name for myself. Educated drug dealer. Okay, favorite. Licensed drug dealer. नाम रखने में क्या जाता है? तुम लोग ने डॉक्टर साहब रखा हुआ है, and what else? Otherwise, I'm trying to look at the names only. You know, so many times it becomes difficult to pronounce. Okay, clear everyone? So it's humidifier. How you identify this image? It provides you with a warm and humidified oxygen, right? High flow nasal cannula. It gives 100% oxygen at 40 to 60 liters per minute. Clear? Okay, next question. Okay, before I go forward, I wanted to discuss this point about CPAP also, but I will take one more question and I will discuss this later. Okay, remember I have to discuss this. I have to discuss this point, non-invasive ventilation and CPAP. I think NEET PG did not have a question, but FMGE had continuous 2 questions based on this point. Dr. Lagnajit says, Nasha Mukti's doctor. हाँ, वो भी ठीक है. Good name. Good name. Next time I'll try to keep it. Imagine you have a class next time scheduled by me. As Dr. Lagnajit says, Nasha Mukti doctor. So next time you will get class by Dr. Nasha Mukti doctor. Aha, sounds good. Half the time the people will come to see ki hai kaun? Who is this person? Okay, anyways, we'll discuss this point. Coming back to what I was discussing, non-invasive and CPAP later on. Let's go back to this. Identify the mask in the image. So there are 3-4 questions like this, which I will discuss now. All these were based on oxygen delivery devices. I'll discuss them together. Okay. Identify the mask in the image. Venturi, Hudson, nebulizer, non-rebreathing. Okay. Everyone correct. Non-rebreathing mask. Correct. How did you identify? It was by the presence of the reservoir. Okay. This is the reservoir bag. So you don't need to know the working or everything. You just need to know how much will it provide, which was again a MCQ question, right? So this is not a Venturi mask. The Venturi mask is not a Hudson mask. Hudson mask is normally a simple face mask, right? The nebulizer itself uses the Hudson mask. Nebulizer has the Hudson valve basically. There you're using it, right? And Venturi mask is the one which comes like this, this shape. Okay, that's the Venturi mask. Highest FiO2 is produced by which of the following? Now, the Venturi, the non-rebreather, Hudson or nasal cannula. These were the simple questions which were asked. And I'll discuss all these questions as a single point. Okay. What's the answer over here? Venturi mask, a non-rebreather mask, Hudson mask, or a nasal cannula. Okay, so yes, most of you are right. Most of you means all of you are right here. Correct. Good. All of you are well prepared. As I said, with anesthesia questions, all of you are well prepared. Don't worry. The same difficult questions I told you which were difficult ones, but you are right. Okay. So now when you are discussing, guys, remember, so we had, as you saw, so many masks over here. From this question onwards, nasal cannula, non-invasive ventilation, high flow nasal cannula, CPAP, BiPAP, right? Then you have Venturi mask, Hudson mask, nebulizer. So when you're discussing all these devices, right? All these devices that they are asked in the exam, and all of them are important ones. So when you speak about the grading, you will, or classification, I basically classify them into 2 types. These are oxygen delivery devices. I feel this is an important question. They can ask anytime. So, you are supposed to be knowing them properly. So oxygen delivery devices, we'll classify them into 2 types. One are the low flow devices, and other are the high flow devices. Low flow and high flow. So the low flow devices are the ones which we can call as nasal cannula or nasal prongs. Sir, please write flow rates in one slide. Okay, I'll write it flow rates as well. Okay, so low flow devices are the nasal prongs or nasal cannula. Then you have the simple face mask, which I told you is also called as a Hudson face mask. You have something called as a partial rebreathing mask, and then you have a non-rebreathing mask. These are your low flow devices. The nasal prongs works between 1 to 6 liters, At 6 liters, it gives around 45% oxygen to the patient. FiO2 45%. This is the maximum. At 6 liters, it gives 45%. A simple face mask works between 6 to 10 liters. At 10 liters, it provides around 60% oxygen to the patient. A partial rebreathing mask works between 10 to 12 liters. At 12 liters, it provides 70% oxygen to the patient. Non-rebreathing mask works between 12 to 15 liters. At 15 liters, it provides 90% oxygen to the patient. Okay. Now, there's a formula to calculate the value for nasal prongs, especially for nasal prongs. It is 21 plus 4 multiplied by the flow rate. Flow rate means flow rate of oxygen in the what you start for the patients. All of you have started oxygen for the patient, right? From the flow meter. What is a flow meter? Flow meter is this. What is attached to that wall? That flow meter. How much oxygen do you start from here? So that is what is called the flow rate. So if the flow rate, as we saw here, is 6 liters, so 6 into 4 is 24 plus 21, you get answer 45. That is only for nasal prongs. Even this was one question in one INI-CET 3 years back. Okay, but I did not take the question because I'm discussing it directly over here. All right, so this question was asked in INI-CET. Okay, so remember the formula is 21 plus 4 multiplied by the flow rate. So if the flow rate is 6, so 6 4s are 24 plus 21, the answer becomes 45. All right, so that is your only for nasal prongs. Now talking about the high flow devices. Now the high flow devices are used now when the patient is not very stable. Till the time the patients are stable and comfortable, we can use the low flow, nasal prongs, NRBM. When you come to NRBM and all, remember the maximum is given by NRBM. Of course, beyond that, it becomes the high flow nasal cannula, which we just saw, that gives 100% oxygen. And remember Venturi mask. Venturi mask is a high flow device, no doubt about it, but the maximum FiO2 by a Venturi mask is only 60%. That's the point. So Venturi mask is what comes in various colors. You must have seen this. So here you will see this green color is you don't need to remember the colors, is 60%. The red one is 40%. You will see the blue one is 24. This is 35. Orange is 31, 28. So this is used whenever you want. These are the Venturi masks. These are based on Venturi principle, right? And they are also called as a fixed output devices because your output is fixed. If you put a green one, it is 60, red one is 40. So these are called fixed output devices. The reason is they work on air entrainment. They entrain air. So oxygen passes from here, air goes in from this hole, it gets sucked inside, right? Because of the oxygen pressure that is going in. And based on that, you will come to know exactly how much oxygen is going. That is called air entrainment. All right. This is used whenever you want to give titrated oxygen to a patient. You don't want to give too much oxygen, but titrated. So nasal cannula, then comes simple face mask, then this partial rebreathing. The difference between a simple face mask and rebreathing mask is presence of a reservoir. And can you see presence of a valve? There is a valve also, right? So you have a reservoir bag, and apart from that, you have this presence of a valve. That's how it is different. Clear? Now I was going to discuss, this is the high flow nasal cannula. And here is the humidifier. Here is the humidifier, which you guys already identified. Now talking about the grading. Grading means the lowest out of all these devices is the nasal prongs or nasal cannula. After that comes the simple face mask or the Hudson face mask. After that, the next one beyond that is the partial rebreathing mask. Then comes as the non-rebreathing mask. Beyond that comes the high flow nasal cannula. After that is the non-invasive ventilation. What is non-invasive ventilation? Remember, non-invasive ventilation is what is going by a face mask. It goes by a tight and a special face mask. It's not the normal simple face mask. It's a tight special face mask that you people must have seen. And what you give from here is basically your CPAP, continuous positive airway pressure, and bi-level positive airway pressure. And because it is going from a face mask, the patient has to be spontaneously breathing, right? Therefore, what are the contraindications? The contraindications to CPAP and BiPAP is in case the patient is unconscious, patient is sedated, patient is having edema on the face, or fracture to the face. All these conditions you can't use Dr. Xavier says, how many questions from anesthesia NEET PG? Depends. The last 2 years, they've asked around 6 to 7 or 8. But you will see they are integrated with other branches there. CPR का question आता है ना, you always get a CPR question, you always going to get an intubation question, you're going to get a LMA question, CPR, emergency, it comes integrated with other branches. So you can make it between 6 to 8, right? It may be 5 at times, but normally it is 6 to 8. In fact, last year we 6 to 8. All right. So here I discussed about the CPAP and BiPAP, right? And after the non-invasive comes the invasive ventilation. Invasive ventilation is when you are giving it from the invasive means you put something inside the trachea. So that goes from the endotracheal tube or through the tracheostomy, right? And it means now the patient is put on ventilator, right? So therefore CPAP and BiPAP have also been important questions, and after that comes the invasive ventilation where the patient is put on ventilator. So that is the oxygen therapy. What you do in the casualty, all of you must have seen this. A patient not doing well, initially in the casualty, you were the casualty medical officers, nasal prongs, nasal mask, face mask, NRBM not improving, shift the patient to the ICU, high flow nasal cannula, we try CPAP, BiPAP not improving, intubate and put on ventilator. The same thing was done in COVID also. The whole pathway is the same thing which was done in COVID. All right. So this is about the oxygen delivery devices. Important question. How does local anesthetic act? Yes. How does local anesthetic act? Inhibiting the sodium channels, decreasing the resting membrane potential, activating the sodium channel, or inhibiting the nicotinic receptor. Oh, I got someone from Marrow also. Marrow A. Dr. Marrow. All right, all of you are correct. It inhibits the sodium channel. Next question. What type of sodium channel? You know, it's not just sodium channel. This question can be expanded. Which type of sodium channel? Next question. Which type? Non-ionized enters from the nerve, ionized blocks, correct. All that is correct. But which type? There are 3 types of channels: mechanical, ligand, and voltage. Nodes of Ranvier, correct. Correct. Local anesthesia works on the nerve. It works on the nerve fiber. Correct. Absolutely correct. On the nerve or the nerve fiber, it is working at the nodes of Ranvier. Absolutely correct. Right. So, correct. Voltage. I give you 3 options, na? Mechanical, ligand, and voltage. These are all exam questions, right? All of them have been asked. Correct. Voltage, na? Are sodium bologe to, so if sodium goes inside, it is voltage gated. Ligand means there is going to be something attached onto it. Mechanical means it's with pressure. Ligand gated is going to be with some neurotransmitter or whatever, right? It's not ligand gated. So these are normally the place where it works the most are the voltage gated inactivated sodium channels. Again, that's exam question. Voltage gated inactivated. If you don't remember my name, Vinish. VIN. Voltage gated inactivated sodium channel. Remember my name, guys. You'll get the answer. Okay. Voltage gated inactivated sodium channel. All right. What does it do? The local anesthesia goes onto the nerve. So when you're giving local anesthesia, guys, remember I insert it inside the tissue, and from the tissue it gets absorbed inside the nerve. Correctly pointed out by Dr. Arpit. Right? He pointed out correctly. So these are the inside the nerve. What will happen? So these are the sodium channels where action potential goes like this, right? So sodium will go inside that voltage gated channel, sodium and action potential jumps. Saltatory conduction, sodium goes inside, it jumps. Sodium goes inside, it jumps. So when you give local anesthesia, the local anesthesia gets, you know, it blocks that sodium channel. So now action potential comes here, it jumps. But now when it goes here, it gets blocked. The point is it has got blocked from where? It has got blocked from within. Correctly pointed out, the local anesthesia penetrates through this lipid membrane. This is what is called lipid solubility. It penetrates the lipid membrane, goes inside, and once inside, it works from the intracellular area because it's the ion channel. The local anesthesia drug will not penetrate from here. It penetrates from here. And that is why in whole of pharmac, lipid solubility tells you what? Potency. Because a drug which is more lipid soluble will penetrate the lipid membrane more, and more penetration into the lipid area through the lipid membrane means more effect, better effect, which is what is called potency. Okay. So therefore, that is how the local anesthesia works. It penetrates through the lipid membrane, goes inside being lipid soluble, and works from the intracellular area. Clear, everyone? So what is it doing? It blocks the generation and conduction of impulse or action potential. It blocks the generation and conduction of impulse or action potential. Right? On the sodium channel, remember, because it is blocking the action potential, guys, it can even work on calcium channels, chloride channels, or potassium channels. But the maximum effect takes place at the sodium channels. Okay? Clear, everyone? डॉक्टर लग्नजीत ने मस्त बोला, गोली लो, नशा दूर करो. Great. We have poets with us. Perfect. Clear, everyone? No doubts till here? Okay. So let me go forward. Okay. So this was about how local anesthesia drugs act. Next question. What is the most common cause of hospital admission after day care surgery? Yes. Day-care surgery. Correct. Absolutely correct. All of you. Absolutely correct. Most common cause of a hospital admission after day-care surgery is post-operative nausea, vomiting. So when you're discussing the complications, guys, remember the commonest complication, day-care surgery means surgery taking place on the same day, patient going home on the same day. You can have small procedures like laparoscopic cholecystectomy, hysteroscopy, diagnostic procedures, lithotripsy, right? All these are day-care procedures. Patient goes home the same day. You can think of MTP, you can think of DNC, suction evacuation, right? Cataract surgery. So these are all day-care surgery where the patient goes home on the same day. What are the commonest complications someone is going to have? Because the patient goes home the same day, remember, one of the most commonest complication is nausea, vomiting, which is post-op nausea, vomiting. Apart from that, pain is also a common complication. But out of the two, we will go with post-op nausea, vomiting. This is the most common cause of hospital admission. The second most common cause is pain. Apart from that, you can get respiratory distress. Patient might be sedated, right? And of course, breathing might be compromised. There is respiratory distress that can take place. Also, there can be surgical complications like bleeding. This may be one of the causes for readmission, means the patient has gone home and then come back again. So a normal patient just vomiting, you will not ask the patient you come back, you just take some medicine. But readmission, you are basically, patient must be having some bleeding, some hemorrhage. In that case, you will ask the patient to come back. So that may be a cause of, Dr. Shivam, that's what I'm discussing. So surgical complications are the most common cause of a readmission. Means the patient has gone home and then you have got the patient again, and that is what has been said. See, no book has given this answer. The anesthesia books have given this answer that hospital admission, the most common cause is nausea, vomiting, and pain. But normally, along with the surgeons, it's always this part that readmission means if the patient has gone home, come back to the hospital again. So just for pain and or nausea, vomiting, you will not call. But if someone calls you up and says, doctor, I am having bleeding, you will not say, oh, stay at home, it will get okay on its own. Someone says there is bleeding and hemorrhage, you will say come to the hospital immediately, whether the patient was of cataract, of hysteroscopy, of gallbladder surgery, of suction evacuation, MTP. No, suction evacuation, MTP, some bleeding might be there. But other conditions, if the patient is bleeding, you'll ask the patient to come to the hospital. Okay. So according to me, that may be one of the points. All right. And that is why we prefer propofol. Correct. That is the reason why propofol is drug of choice for induction anesthesia, because propofol has antiemetic properties. Very good. Absolutely correct. Because propofol has antiemetic properties. That's why propofol is the drug of choice. For induction, not for PUNV. Otherwise, what is the drug of choice for PUNV? Next question. For post-op nausea, vomiting, what is the drug of choice? Yes. Post-op nausea, vomiting, what is the drug of choice? Yes, ondansetron. Exam question, ondansetron. Absolutely correct. Right, so we finish off this question also. Next one. Okay, simple. The given image of a green cannula. What is the number? Correct. Correct. All of you have used it. It shows your practical experience also. All of you are absolutely correct. This is the 18 gauge. Okay, so when you speak of IV cannula, they're all important. The 14 gauge, 16, 18, 20, 24, and remember there is 26, which is purple also. Okay, the 26 gauge is purple. Right, so you will find, as I discussed before, 22, 24, 26. So 20 is the most common used in adults. 22, the blue one, can be used in adults or can be used in children. Right, 24 is used in pediatrics, can be used in neonates, and 26 is used in neonates and preterm neonates, which means between 22 to 26, these are thin gauge or thin bore. These are not thick ones. These are thin. Right? And you will find these ones to be thick. These are thick gauge. They are basically used for thick bore or thick gauge. They are used for fluid resuscitation or giving blood. Remember, there's one 17 gauge also, which is white in color. It's not available in India. There's one 17 gauge which is white in color. Okay, which is one used in, which is white in color. Again, that's a thick one. I have not seen it, but I just read about it. Okay, so 17 gauge is also there, white in color. Right, so many times they might ask you regarding the flow rates. So flow rates, remember, so around 50 is the center one. You know, this is the most common used in everyone. You will find the pink one, all of you have used it maximum, right, in adults. It will give somewhere around 50. The thick ones will be double of that, 80, 180, 270, that's the flow rate. And the smaller ones will be half, so 33, 20, and here it is around, the purple one will give you around 13 to 15 ml per minute. Okay, the purple one, this one is around 13 to 15 ml per minute. This is the flow rate. All right. All of you know that, no? Oh, great God, please bless your pupils. Oh, great God, please. I think you're aware of that. Answer this, discuss. Huh? All of you to be knowing that. Please bless. How many more questions? Even I don't know. Wait, even I don't know. Let me see how many questions. I kept on discussing. I did not keep a time. Anyone in hurry? Let me see, Dr. Sangeet. I think 3, 4 more. How many more? 1, 2, 3, 4, 4, 5 more. 5, 6, 7. हाँ, 1 घंटा और लगेगा अपने को. 30 minutes to 40 minutes. Final भी तो है. बस this is the last one here. So 1, 2, 3, 4, 5, 6, 7. बाकी सब तो simple है. These were the ones where we discussed. This is where we were. Another 8, 6 to 8 questions, I think. 8. Right, so we finished till here. अरे सब क्वेश्चन है यार, मतलब मैं तो जितने भी क्वेश्चन मिले वी ट्राई टू यूज ऑल द क्वेश्चन ना. PYQ था. What's the point in me discussing half? Wait, just give me a second. My phone will get discharged. How will I see your messages? 1 second, guys. Just hold on. All right. I had to shift slightly. I was charging my phone. Yeah, my phone was not charged. Then I not see the messages. Okay. एकदम साइड में रखना पड़ा यार फोन को. Visible and audible now? Let's go fast. Let me finish off. So the next question is, a 45-year-old male is found unconscious on the road. A thorough assessment reveals that the patient has cardiac arrest. If you handle such a patient at the event site, which of the following would be your first step in managing a patient according to ACLS guidelines? Check the pulse, CPR, call for help, and shock if available. Second is call for help, check pulse, CPR. Third is observe, and fourth is just CPR. Fast. Yes, guys. Which one is the correct one? ओके मेरे को इमेजेस थोड़ा सा यहाँ पे देखना पड़ रहा था. करेक्ट. सी फॉर जस्ट चिल. नहीं सी नहीं आंसर. द पेशेंट हैज कार्डियक अरेस्ट. ठीक. सो विच ऑफ द फॉलोइंग वुड बी द फर्स्ट स्टेप? ऑल ऑफ यू आर, most of you have given an answer A. Hardly I could find B. B is the answer, guys. You are not going to check the pulse first. Remember, the sequence becomes important. Call for help, check pulse, and do CPR. Okay. So a patient has cardiac arrest. Okay. Patient has cardiac arrest. They have said what is going to be your first step in managing a patient according to the ACLS guidelines. They have not mentioned anything else. They have not mentioned. Remember, just based on what has been given, the first step always is scene safety, that everything is okay. The second step is check for response. If the patient is responding, things are fine. If the patient is not responding, remember the third step immediately is call for help. Till now, you have not checked for the pulse and breath. After the scene safety, the first step was scene safety. कुछ भी करने के पहले scene safe होना चाहिए. You're aware ना? Before doing anything in life, scene should be safe. Don't do anything without scene safety. Even CPR. Scene safety means it should be safe for the victim, safe for the rescuer, and take standard precautions. The scene should be safe. Don't add to the victim. Don't make two victims over there. Right? Check for response is the second step. The third step is call for help. Until now, you've not checked for breath and pulse. The fourth step is where you check for the breath and pulse simultaneously in 10 seconds, right? So if you get the breath and pulse both in the patient, both of them positive, breath is also there, pulse is also there, keep the patient in recovery position, right? If you find the breath missing and pulse present, what is missing is the breath. So you give breath. And if you find both are missing, breath as well as pulse, this is where you start the CPR. So therefore, call for help, then you check for breath and pulse, and depending on what you find out, then you start the CPR. That is the answer. So call for help, check the pulse, do the CPR. You don't call for help after checking the pulse. Call for help comes before. Thumbs up, everyone. Is that okay? The ones who made slight mistake. Yes. All right. Okay. Right. Okay. So clear, everyone. So this is about your the points. Yeah, the phone has become so far away. I can't even see your messages. Do chala gaya. Wait. Let me just. Yes, much better. Okay. Now. So this is the point. Once you started your CPR, then what are the points for CPR? That is also an important question asked in the exam. So when you're doing CPR, remember now it is CAB, chest compression, airway breathing. Chest compression, when you give, it's always lower 1/3 of the sternum. The rate is 100 to 120 per minute. The depth is 2 to 2.4 inches or 5 to 6 centimeter. Okay? It is basically 1/3 the depth of the chest, and always allow a chest recoil. These are the 4 points for giving chest compression. Airway, you are supposed to do the maneuvers so that you remove the obstruction, right? So those are the airway maneuvers, and you have to remove the vomitus. All right, so that is airway. And once that is out, you give breath to the patient. So giving breath can be given mouth to nose, mouth to mask, bag mask. all right, and no excessive ventilation. Clear? So next point beyond that. So this is what you do. And when you start your CPR, remember till now we were at the 5 steps ना, ये 5 step थे हमारे. Scene safety, check response, call for help, then look for breath and pulse. This was my 4th step. 5th step was start CPR, and in case you get a defibrillator, that becomes our 6th step. When defibrillator comes, you check for the rhythm. If the rhythm is shockable, give the shock. Remember, after the shock, again this was an MCQ question, no pulse check. Immediate resume CPR. This was again an MCQ question. Once you give a shock, no pulse check after that, immediately resume CPR. In case a non-shockable rhythm, resume CPR, right? And after 2 minutes, again go and check for the pulse, not check for the pulse and then check for the rhythm. So check pulse, check rhythm, and then look at that. Okay, that's how you do. Clear, everyone? Thumbs up, guys. All okay? I have to look a little bit on that side because I've kept the phone that side. It's not right in front of me, so I can't read directly the messages. Slightly दूर से आ रहा है. Thumbs up, guys. All okay? We'll go to the next question then. I'm not getting your messages. Thumbs up, guys. Anyone? Yes. Now I got the thumbs up. Chalo, next question. Okay. 15-year-old boy presented to the emergency department with difficulty in breathing, stung by a bee. On examination, wheezes are heard, lips are swollen, BP is 80 by 55. Epinephrine is injected as a part of management protocol. What's the correct route and concentration? NEET PG question. INI-CET FMGE. ADR कैसे देंगे? कितना देंगे? Okay. हाँ डॉक्टर अर्पित rejoin ही किया. Rejoin, refresh. Same thing. All right, anaphylaxis, absolutely correct. We are discussing anaphylaxis, right? Anaphylaxis, intramuscular 1:10,000. Sorry, 1:1000. This was again a question in last year's INI-CET where they had asked you about a pediatric patient. Okay, this was last year's INI-CET question. Okay, so intravenous, guys, remember it's given during CPR. All right. And 1:2 lakh or 1:1 lakh, this is used for local anesthesia. So always when there is anaphylaxis, this is the concentration you are supposed to use. Okay, subacute की बात नहीं कर रहा हूँ, but I am saying normally for local anesthesia it is 1:1 lakh to 1:2 lakh. All right, that's what is done. Clear? So this is the route of administration. Next question. Blue pipeline in the OT is for which anesthetic gas? हाँ, route of administration ये आई भी था ना. हाँ, वो all I discussed that. और वो सब हो गया discussion यार. Next, blue pipeline in the OT is for which gas? Simple. Correct. Right. So these gases are important. Oxygen is what color? Oxygen is what? This is a pipeline. I am discussing about a pipeline. Pipeline is not the same as the cylinder. So anyone, what prevents the wrong attachment of pipeline? What prevents the wrong attachment of pipeline? Yes. डॉक्टर अर्पित, यहाँ पे पिन इंडेक्स नहीं आएगा, वही मैं इसीलिए बोल रहा हूँ. That's what I'm discussing. राइट. एक तो इनिशियल ये करेक्ट था, ऑक्सीजन वाइट ये करेक्ट है, इसमें नथिंग रॉन्ग हियर. No, pin index is not right. It's called diametric index safety system. This is where we get confused. Diameters, it's based on diameters. If pin index safety system is for cylinders and not pipeline. Remember, this is diametric index safety system. It prevents the wrong pipeline connection. It prevents the wrong pipeline. So these are the various pipelines that you see. So oxygen is white in color, nitrous is blue in color, air is black in color, and vacuum that we use for suctioning, that is yellow in color, right? So therefore, to prevent the wrong attachment of pipeline, it is called diametric index safety system, not pin index. diametric index safety system. Okay, it is not pin index safety system. It is diametric index based on diameters. Now, how to remember? Because now normally what happens, people think like this: P for pin index, P for pipeline. This is what you think. Even I used to think the same way, nothing wrong, because we always try to find correlations. P for pipeline, P for pin index. But it's wrong. To make it different, remember like this: for pipeline, it is diametric index, right? And for cylinders, it is pin index. Okay. So for pipeline, it is diametric index, and for cylinders, it is pin index. So what I can do is, to remember, I can just change it slightly. What I will do is like this: pin index safety system is for cylinder. I'm just telling you way to remember. Diametric index safety system is for pipeline. So what do? I take the initial words P, C, D, P. Just remember the two famous actresses, Priyanka Chopra and Deepika Padukone, and you will never forget ever in your life. Clear? Pin index is for cylinders and diametric index is for pipeline. Now you will not get confused. Thumbs up. That confusion is over. Just remember the actresses. Is that okay, everyone? Are you were getting, all of you gave me the answer pin index safety system for pipeline. Are pipeline ka pin index nahi hai, because we think P and P. No, don't think P and P. P, C and DP. You get your answers. Clear? Yes. अब सबको समझ में आ गया. Now no one will forget. Now you will not forget pin index and diametric index. Let's see the color of cylinders. I'm going to take some time, guys, because timing was not fixed. I'll take it till almost 8:45-9. I'll finish off by 8:45-9. 3 hours to लेना ही चाहिए ना. 3 hours is almost a complete revision of all the PYQs and all the topics of anesthesia. It's not about finishing how fast, but I want you to discuss everything. Okay? No problem. Correct. So let's go forward. I am discussing the color of the cylinders. Remember, air color is, what is the color? Gray body with black and white shoulder. Correct. Pin index is 1,5. Oxygen, the color is black body with white shoulder. Pin index is 2,5. Nitrous oxide is blue in color. Pin index is 3,5. Right? These are the three major that they ask you in exam. Sometimes they may ask you Entonox. Entonox is a combination of oxygen and nitrous. So Entonox is blue with blue and white shoulder, or blue with white shoulder. Pin index is 7. Carbon dioxide is gray in color and the pin index is 1,6 or 2,6. All right, it depends on the percentage of carbon dioxide added to it. Remember, Entonox is a combination of oxygen and nitrous. And Entonox cylinder, where is it used? So Entonox is commonly used for pain relief during dental procedures or during labor analgesia. But remember, for labor, the best is always an epidural. Okay, so these are the pin index numbers, and also beyond this I will discuss with you the color of vaporizers. When you discuss vaporizers, remember halothane is red in color, isoflurane is purple in color, desflurane, remember special vaporizer, that is blue in color, and sevoflurane is yellow in color. So these are the colors which are important. So Dr. Pratisha says, sir, gray body, black and white shoulder. That is gray body, that is air, no? Correct. You gave a correct answer there. Okay. I just mentioned all of them. The discussion ho gaya. Next, what is the mechanism of action of the curare group of muscle relaxants? Okay. What is the mechanism of action of the curare group of muscle relaxants? Persistently depolarizing at the neuromuscular junction, competitive blocking the binding of acetylcholine to its receptors, repetitive stimulation of acetylcholine receptors on the muscle end plate, or inhibiting the calcium channels on the presynaptic membrane. Yes. So when you're discussing curare group, correct answer is yes. All of you have given correct answers. All of you have given correct answers. Absolutely correct. Okay, that is competitively blocking the binding of acetylcholine to its receptors. Okay. So what about the action of succinylcholine? Succinylcholine. So this is about the curare group. So when you're discussing the muscle laxant, guys, remember the muscle laxants are of two types. Okay. One are the non-depolarizing, other are the depolarizing. So just remember the non-depolarizing is going to prevent depolarization, and depolarizing is going to prevent repolarization. Right? Which means depolarizing is going to cause depolarization. Which means non-depolarizing has no depolarization. Simple ना? ये तो नाम में लिखा है. The point is, if depolarizing is causing depolarization, it means it is similar in action to acetylcholine, which means it is going to working similar to acetylcholine, which means it mimics acetylcholine in action, and that is your succinylcholine. Okay, and therefore when you speak of non-depolarizing, so because it mimics acetylcholine, succinylcholine becomes non-competitive in nature. On the other hand, non-depolarizing has no depolarization, right? So are they going to be similar to acetylcholine? No, they are going to be something different to acetylcholine. They may be opposite to acetylcholine. They may be duplicate to acetylcholine, opposite to acetylcholine. So does it mimic acetylcholine? No, that is why it is called non-depolarizing. So all the drugs, vecuronium, rocuronium, atracurium, pancuronium, all those curare drugs that you saw, they are opposite to acetylcholine. So is it non-competitive? No, that becomes competitive. Easy. So therefore, all these drugs are competitive antagonist because they are going to prevent acetylcholine action. They are going to be antagonist at the receptor, and because it mimics acetylcholine, succinylcholine is to be the agonist at the receptor. Basically partial only, but it is agonist. All these points are exam questions. Clear everyone? Okay. So depolarizing is succinylcholine. It causes depolarization. It prevents repolarization. It is similar to acetylcholine. It mimics acetylcholine. It is non-competitive. It is agonist at the receptor. All the points fall in place, right? On the other hand, non-depolarizing are the ones which prevent depolarization. So they do not cause depolarization. So they are working opposite to acetylcholine, right? So vecuronium, atracurium or rocuronium, they are not like acetylcholine. So are they similar? No, they're different. So that's why they become competitive, and that is the answer to all the questions. They are competitive antagonist. Clear? So therefore, when you speak of this answer, competitively blocking, they are competitive antagonists. So these become your non-depolarizing muscle relaxant, and persistent depolarization, which means it causes depolarization like acetylcholine. This is succinylcholine. Thumbs up. Clear everyone? Right? So all non-depolarizing and depolarizing, the mechanism of action hopefully is clear for all of you. I know all of you have studied, but this was just a revision for that. Hopefully this point is clear to everyone. Okay, next. Dr. Sapna, thank you, Dr. Sapna, made my day. Thank you guys. Messages like that make our day, thank you so much. Okay, feels good. That's why we if you understand some point also, it makes us feel good that we were able to put across some point in your mind. Okay, hopefully something or some clarity that you people got. Thank you. Next, which of the following is not used for induction in pediatric patient? Yes, everyone. Answer. Dr. Gayatri, read the question. Dr. Pratiksha. ये गलत बात है, मैं तो अभी तुम लोगों को पढ़ाया. Wait. All of, how can you mark the answer A? See, that's how they confuse you in exam. See, don't get confused like this. See, anesthesia are easy questions. These are scoring questions. Where is that question gone? See, look at here right now. This is what we had discussed. Halothane and sevoflurane are both sweet smelling. They are both bronchodilators and they can both be used in a pediatric patient. Do you see this? I have written it here also. Though halothane is not preferred, sevoflurane is preferred, but we can still use sevoflurane as well as halothane for a pediatric patient. So therefore, what is the correct answer in that question? Absolutely correct. Yes, it is desflurane. Because why will you not use desflurane? Because it is pungent maximum bronchial irritant. That is how they confuse you in exam, guys. All simple questions are there. These are the places where we lose marks. Good. For all the students who answered correctly, very nice. This was a question where you just had to think. Okay. So halothane can be used. They are not asking you drug of choice. Of course, drug of choice here is sevoflurane. But can you use halothane? Yes. Can you use nitrous? Yes. Desflurane? No. We can't use desflurane because it is a bronchial irritant. Remember, it's the maximum bronchial irritant. Thumbs up. Clear, everyone? हाँ डॉक्टर गायत्री, यही तो होता है एग्जाम में. यू गाइज, यू नो, एवरीवन, सी, ऑल ऑफ यू हैव स्टडीड वेल, you have read well. Again, the same thing. Please solve MCQs. Why we tell you to solve MCQs? It's not because of your knowledge is poor. It helps you to realize how they are confusing you with questions. Because that is how they will segregate students, na? Not that you have not studied. All of you have studied. You are well prepared. But read your questions correctly. This is where we make mistakes, right? And to make, for this reason, don't read too much. Solve more MCQs. Have more MCQs and analysis that where we are making mistake. This is the way to go forward. Okay. And as I told, make mistakes over here, guys. Whatever mistake you make here right now in the session, it's an extra mark in the exam. Think like that. Think like that. Whatever mistakes are happening here, your doubt has got cleared and you will not make that mistake in case this question comes in the exam. It's as simple. Okay. Next, we are done with this also. So last में रखा था ये, revision हो गया. Which of the following agents does not elicit pain on injection? Okay. None of you, please don't be dejected. My point is not to put you down. Please, guys. My point is just to tell you to make mistakes over here because that clears out your doubt. It's fine. Now all of you will be careful when you're reading the questions. That was the point. Please make mistakes here. It's okay. Making mistakes here is fine. Don't do that in the exam. That's the point. When you guys succeed, we feel we have succeeded. Okay. At this stage, we feel happiness in your success. It feels as if we have cleared some exam. Okay. All the platforms, why do you think all of us jump? At one stage, it does not care what degrees I have or what thing I am doing. Now what we care is what other people are getting, how you help someone else to achieve that. Okay, so it makes us feel good. Correct, ketamine, sab log correct, absolutely correct. Ketamine, it's one of the best drugs, guys. Ketamine. You know someone who's expired with ketamine? Anyone? Anyone? Not an MCQ question for the exam. Out of MCQ question. Someone who was a very good actor but addicted to ketamine, as per what the reports say and what was found in the blood reports. Dr. Shivam says MJ nahi, MJ was propofol. Michael Jackson was here, propofol. Michael Jackson was here. This was MP, Matthew Perry, correct. Chandler, correct. Nahi, Michael Jackson was propofol. Propofol was Michael Jackson. This is not asked in the exam, by the way. Matthew Perry is ketamine. Friends, that's Chandler. Correct. Dr. Baby Sende says Karan Johar nahi yaar. वो कहाँ से आया? Yes, ketamine is one of the best drugs here. Ketamine. Same way. Now, if I can change the answer. Now, if I have to ask you, which of the following agent does not, let me change the question here. Sorry, I just want to change the question. Which of the following agent does not work on GABA receptor. Okay, next. Ketamine में बहुत मजा आता है. Euphoria क्या? You've never seen pediatric patients with ketamine. No, I can't say. I'm on YouTube. Otherwise, I wanted to say many other things. I'm not saying here. Okay, it is online here. I can't say a lot of things. Otherwise, you know, my heart is the words are coming, just waiting to come out of my mouth regarding ketamine. I'm not saying that. I'm holding myself. You know how much I'm holding myself. Answer me this question, guys. Same options. Which of the following agents does not work on GABA receptor? नहीं मेरे को कुछ नहीं बोलना अभी. Nothing online. डॉक्टर लग्नजीत ने कुछ बोला करेक्टली. Okay, and Dr. Arpit is absolutely right. Absolutely right, because the question is what works on which receptors, guys. So all these three drugs, propofol, etomidate, thiopentone, they all work on GABA receptors, right? Ketamine is the one that works on NMD receptor. And because it works on the NMD receptor, remember ketamine out of all of them is the only analgesic drug. Remember, all of them are painful injections. They ask you in the exam the most painful and all. So ketamine is the one which is analgesic, and propofol then becomes the most painful. These drugs work on GABA receptor. All of them are painful injections. Not just because of that, these two are painful because they are emulsions, and thiopentone is painful because of the pH. The pH of thiopentone is 11.8. It's a very basic pH. Normal pH, sorry, 10.8. Normal pH of the body 7.35 to 7.45. Because of the basic pH, it is painful in nature. And propofol, etomidate are painful because of emulsions, but ketamine is analgesic drug working on the NMDA receptor. Okay. All right. Next, I'm just going to discuss the drug of choice here also, just like I discussed with inhalational agents. As I said, this is very important in exam. And again, this is what I feel. For CVS, always remember the best drug is etomidate because it maintains the cardiac output like isoflurane. It's the most cardio-stable IV anesthetic agent, but the point is many times in cardiac patients, especially with low ejection fraction, in low ejection fraction, we prefer to use opioids also. Okay, so do remember opioids are also drug of choice in a cardiac patient, right? Okay. And Dr. Itachi says propofol causes hypotension all the time. Yes. Of course, propofol. See, when you discuss I'll come back to later. Pharmacodynamic properties. So if you take CVS, RS, CNS, thiopentone. So you can think like this, that thiopentone is going to depress the CVS slightly, slight decrease in cardiac output. It causes respiratory depression and apnea. And CNS, it decreases intracranial pressure, decreases cerebral blood flow, anticonvulsant. Right. When you speak of propofol, make it double. A double decrease in the cardiac output, hypertension, in double decrease. That's why Michael Jackson is decreasing the respiration completely, leading to apnea, propofol. Right. That's why Michael Jackson. Same reason. This is the reason. All right. And these properties of CNS are same as thiopentone. All right. Etomidate has no change in cardiac output. Yes, there's going to be respiratory depression. It's bound to be there. And in CNS, it basically causes focal seizures, or, you know, it can be used in CNS. I'm not denying, but myoclonus is known to happen. Ketamine, just make it opposite. Look at propofol and make it opposite. The answer is ketamine. It increases everything in the cardiac system. It kind of increases respiration, not increases, but it maintains respiration. And everything in the CNS is increased. The same answer which Dr. Arpit gave me initially. It increases everything in the CNS, right? But it maintains respiration. Also, you will not use ketamine in a cardiac patient. Why? Because it is increasing the cardiac output. It is increasing the oxygen demand also. That is ketamine. So ketamine is just opposite to propofol. Whatever answer you gave for propofol is just opposite. This is ketamine. Clear? These are pharmacodynamics. All right, ये हो गया. Coming about the drugs. Dr. Arpit says propofol infusion syndrome. ठीक है, उसको भी 2 मिनट में I'll teach here only. 2 minutes. Let me just finish off the drug of choice. I'll come to that. CVS में etomidate, low ejection fraction, and etomidate are drugs of choice. Then when you speak of a respiratory patient with active bronchospasm, who's having bronchospasm right now, as of now, someone having bronchospasm, or you get a patient with status asthmaticus, a pediatric patient who has an IV cannula, a patient with shock or shunt, tetralogy of Fallot, all these patients, your drug of choice is ketamine, and ketamine is one of the best drugs. It maintains respiration. Okay, though it maintains respiration, but at one point is anesthetic agent, and that is why Matthew Perry also, okay, he was addicted to ketamine. See, all the anesthesia drugs, they are abused, huh? All of them, all the anesthesia drugs are abused. Ketamine, antidepressant. This time's INI-CET question. Antidepressant, ketamine, if you remember. INI-CET, ketamine, antidepressant. It is used for out of OT anesthesia. All right, burn dressings, short procedures. Full stomach patient. Right, CNS, opthal, ECT. The best drug is thiopentone, but books have now said that no, propofol is as good as thio, so we prefer to use propofol as a newer agent, better than thio. But thio has other properties. It decreases raised intracranial pressure, status epilepticus, and narco analysis. So thiopentone is also used for narco analysis, right? Apart from that, everywhere else the answer is propofol. Apart from what we have mentioned over here, everywhere else the answer is propofol. Everywhere else. It also has antiemetic, antichlorotic properties, but everywhere means renal patient, liver patient, day-care surgery, intubation, sedation, malignant hyperthermia, porphyria, ICU sedation, you name it, even respiratory patient with no bronchospasm. Everywhere else the answer is just propofol. And then there was answer about propofol infusion syndrome. Okay, और कुछ था? Ketamine is dissociative. Yes, I remember ketamine is increasing everything but cardiodepression. Yes, ketamine does cause FC, but initially it increases everything. The heart rate increases, BP. It's because of the sympathetic stimulation that is taking place. Dr. 𝐒𝐿𝐿𝐿𝐿𝐿. Okay, or that's what. Yes, ketamine 1 with nasal. It can be given from all the routes. That's also an MCQ question. So ketamine can be given from all the routes. There are 3 drugs that can be given from all the routes except subcute, and that is ketamine, midazolam, and opioids. Ketamine, midas, and opioids. Okay, they can be given from all the routes. ये हो गया. Methotrexate, drug of choice in ECT, but you don't use it because of HP axis suppression. Okay, ये हो गया. If asthma, only ketamine or halothane. See, remember, these are IV induction agents. These are induction, right? So it depends whether they are asking you IV or inhalational. If they ask you IV, the answer is ketamine. Inhalational, the answer is sevoflurane, right? Best neuroprotective, propofol. No, if you matlab propofol and thiopentone both, ideally they will not give you, but both are neuroprotective agents. That property that we discussed, where is that property? Where did we discuss? This property is called cerebroprotective. This property that we see, decrease intracranial, this is called cerebroprotective property. Now I have to discuss about propofol infusion syndrome. So propofol infusion syndrome. So remember guys, propofol is basically containing egg lecithin, glycerol, and soybean oil. These are the contents: egg lecithin, glycerol, soybean oil. These are the contents of propofol, right? So propofol, when you give, remember, I've just discussed with you, it is a drug of choice for, I told you, induction sedation, ICU sedation also. I mentioned that ICU sedation also drug of choice. So normally when you give propofol, especially to a pediatric patient who is admitted in the ICU and he's on the infusion of propofol for 2 to 3 days, right? Imagine a small child on infusion of propofol getting egg lecithin, glycerol, soybean continuously through an infusion. Now the baby's liver is not that well developed to handle so much oil, so much glycerol. So it leads to failure of free fatty acid metabolism. Krebs cycle. Because it leads to failure of the free fatty acid metabolism, it leads to accumulation of the lactate, which means it causes lactic acidosis or metabolic acidosis. Along with that, the muscles get affected, leading to cardiomyopathy. It leads to acute cardiomyopathy because the muscles have got affected, acidosis, and it also leads to skeletal myopathy, right? And now the muscle damage has taken place. This would lead to a renal failure, liver failure, and death of the patient. This is propofol infusion syndrome. Normally seen in pediatric patients admitted in ICU. This is your propofol infusion syndrome. All right. Clear? हाँ, बाकी पॉइंट्स में नहीं किया मैंने. सॉरी, मैं थोड़ा सा मोबाइल अपने से दूर रखा था. आई एम टेकिंग इट अगेन क्लोज. आई थिंक now I can charge sufficiently. All right, clear. Propofol infusion done. What are the other questions? Let me just see. Dr. Dibaki says, I remember ketamine has increase, kite increase everything but cardio depression. Treatment resistant depression. Yes, ketamine new nasal spray ho gaya. Propofol has falling, everything falling. Corrective asthma, only this, correct. Neuroprotective, yes. Okay. Dr. Pratiksha says green urine. हाँ, green urine भी होता है ना. That green urine also seen with propofol. So you, apart from this, that so much when all that is again side effect, but they've not asked you in exam here. Don't go into that much, right? So if there is increase in lipids, there is increase in triglycerides, and all that also leads to green urine. Right, all these are the side. In fact, hiccups and myoclonus are also side effects. These are the side effects of propofol. Hiccups and myoclonus. Though maximum myoclonus is seen with etomidate. Do we give propofol in pediatrics? No, ideally should not. We give it. Practically speaking, a lot of people give, but ideally they say it should avoid. Where do you avoid propofol? Propofol is avoided only in 2 conditions: pregnancy and neonates. But they say pediatric patients may normally 1 dose is okay. Don't give an infusion. Okay, so that's the point. Ideally, don't give it in pregnant patients. Its safety has not been established, and neonates and pediatric patients 1 dose can be given, but beyond that you don't give it. Okay. Dr. Shivam says when you give ketamine bronchospasm, it will lead to hypersecretion of mucus. Arey, that is why na ketamine is never given alone. मैं तो आगे question पे नहीं जा पा रहा हूँ. It's okay, no issues. You have your doubts cleared. I don't mind. So Dr. Shivam, ketamine, no doubt it is going to increase secretions, right? It's causing thalamocortical limbic dissociation. When you speak about ketamine, correctly pointed out by all of you, it causes dissociative anesthesia, right? So ketamine produces a thalamocortical limbic dissociation. So one area of the brain gets depressed, other gets stimulated, all right? And ketamine also leads to increased secretions and increased muscle tone. Right, and also the presence of hallucinations. Right, hallucinations hota hai, dreaming hota hai. All these are side effects that you get, increased secretions. And that is why ketamine is never given alone to a patient. Whenever you give ketamine, guys, remember you always combine it with a benzodiazepine midazolam to decrease the incidence of hallucinations, and you combine with glycopyrrolate or atropine to decrease secretions. Never is ketamine given alone to a patient. Clear? Dr. Shivam? Dr. Pratiksha says what is given in pediatric sevoflurane or ketamine. So remember, Dr. Pratiksha, if they are asking you induction, inhalation induction, normally the answer is sevoflurane. But if they have given a pediatric patient with IV cannula, then the answer becomes ketamine. So whenever they will ask you about ketamine, they will mention IV cannula present. So remember, whenever this question comes about a pediatric patient, they will always mention, or it has to be mentioned, IV cannula. If there is no IV cannula, then your answer is sevoflurane for a pediatric patient. Is it okay? Clear? चलो चलो नेक्स्ट क्वेश्चन यार फटाफट खत्म करें. आई नो योर पॉइंट टाइम, मतलब मुझे कोई दिक्कत नहीं है, बट होपफुली यू पीपल don't get bored up. Yeah, I finished off almost everything there. Next, which among the following is the most commonly used to monitor the depth of anesthesia? Okay, simple question. Thank you, Dr. Pratiksha. Hopefully it's good for your revision. Hopefully this session is good for your revision and hopefully you gain from it. Thank you. नहीं डॉक्टर देवाकी, इसमें वो आंसर ही नहीं दिया ना. वो तो डेप्थ ऑफ एनेस्थीसिया में कैप्नोग्राफी कैसे आएगा? हाँ, now you're right. Bispectral index. Correct. Bispectral index. Okay, let me change the question. The question is, which among the following is not used to monitor the depth of anesthesia? Let me change the question with the same options. I think all of you are well aware of bispectral index. I'm not going to that much detail, but I just changed the question. Which among the following is not used to monitor the depth of anesthesia? Correct. In that case, the answer becomes B. Normally, basically, it's a esophageal manometry. Esophageal manometry will measure the pressure of the esophageal sphincter. A lower esophageal sphincter monitor जो होता है, that is called provoke lower esophageal monitor. Not very important, but this was one option perhaps given in the exam. Okay. What is entropy? Okay, good question now. So entropy, is EEG and entropy bispectral index all used for depth of anesthesia? Yes. Bispectral index is based on electroencephalogram. EEG is the same thing, right? So both of them are used for monitoring the depth of anesthesia. Entropy, on the other hand, think of it as a combination of EEG plus EMG. It basically tells you about the muscles also. So you get two information from entropy. So if someone will ask you which is a better monitor, entropy or bispectral index, ideally, according to me, entropy is a better monitor than bispectral index, because you're getting to know two things. It's not about just the brain consciousness. As all of you only have told me that bispectral index gives you a value between 100 to 0, and a 40 to 60 is considered for general anesthesia and 60 to 80 is considered for sedation, right? This is a awake patient, and 0 means a flatline EEG, coma. So 40 to 60 is GA and 60 to 80 is sedation, correct? So therefore EEG gives you that value. Based on EEG you are getting that. So EEG tells you depth of anesthesia, bispectral, but none of them will talk about the muscle. Entropy talks about the muscle also, and that's why it's a better monitor. Clear, Dr. Marrow? Clear. So entropy is EEG plus EMG, electromyogram, combined together. Okay, there are two values that you get on it. You don't have to go into details, but just remember that is entropy. Next, okay, which of the following is measured by the device shown in the image? Which of the following is measured by the device shown in the image? Correct. Okay, the point was not to get confused with inspired oxygen, partial pressure, oxygen content, none of that. Answer is oxygen saturation, right? The other oxygen content and partial pressure, all this you will get to know from the arterial blood gas sample, ABG, right? Oxygen saturation normally should be more than 95%. Apart from SpO2, you can also get to know the pulse rate of the patient because it is based on the pulse. You can also come to know regarding the plethysmography waveform, right? You get to know about the arrhythmias. So it tells you the pulse rate. It tells you the perfusion index, right? And there is this waveform that you get, this waveform of the pulse oximeter. It is called plethysmography. This talks about the volume status. Okay. Ideally they say right hand, first finger. Okay, ऐसा कुछ है नहीं, but normally they say the right hand, index finger. But more important is what are the other places where you will use, okay, rather than just one. So there are other places that you can use a pulse oximeter: finger, toes, ear, nose, and then some books have mentioned tongue also. periphery, but you can't have a patient having a tongue outside and a pulse oximeter on the tongue all the time. Okay, so finger, toes, ear, nose, these are periphery that you can see. But if you get all those patients nowadays in all the hospitals to come, I mean, I'm not talking about government hospital, but you get a patient coming in emergency, with all these earrings, there's nose pin, and all those nail art. Don't call it nail paint, it's called nail art nowadays, boys. Other people get offended. Don't say nail paint, it's called nail art. So when you get nail art everywhere and all these rings, in that case, what is left? You must have seen that in an NICU, that is the wrist and the sole. In fact, all of you have seen that, there are watches which are telling about the SpO2. So apart from finger, toes, ear, nose, there is wrist and sole also where you can see it. And this is commonly used in a pediatric patient or a neonate. You must have seen it in the NICU. Okay? Okay. I know you are thinking other places also. I'm not going to talk about it. Correct. You're thinking that also. Periphery areas. Right. I know. Understood. Next question. Which of the following investigation provides the most accurate prognostic information with respect? This was again an INI-CET question. It's a difficult one, but just think about the answer. I'll tell you what is the answer. We'll not discuss this too much in detail. Okay. Which of the following investigation provides the most accurate prognostic information with respect to predicting the risk of a perioperative cardiac complication? This was a question based on pre-anesthetic checkup. Okay. Yes. 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 All of you are already right. Already right. Okay. Absolutely correct. See, according to me, the answer is going to be a dobutamine stress echography. Okay, echocardiography is one of the best things that you will say. You are not, as an anesthesiologist, you are not going to talk about the coronary angiography, or this is the point to be taken up by the cardiologist. So for me, what I will be doing is asking the patient about the ECG of the patient. Remember, I told you about the METs, metabolic equivalent. Why was that important? Because that is telling me about the cardiac function. So for the cardiac function of a patient, I'll be looking at the ECG of the patient. I'll be looking at the METs of the patient, functional capacity. And if the results are not very distinct, then I will go for a stress imaging. Stress imaging means your dobutamine stress echo. So I'll be going for a dobutamine stress echo. And after that, the angiography is planned by the cardiologist. But for us, the answer is a dobutamine stress echo. Okay, all of you give me a correct answer. Not much to discuss over that. Okay, don't want you to discuss so much about it. Right. Next question. A question like this came in FMGE also. It was asked in NEET PG as well. A patient is given a nicotinic receptor antagonist as a muscle relaxant. Which drug is given post-operatively to recover, okay, from the muscle weakness? This was asked in FMGE also, January exam. And this question is a direct question from NEET PG 2022. Right? Correct. The answer is neostigmine. Right? To recover from the muscle weakness, we give neostigmine. See, isostigmine is also anticholinesterase, but it is not used. Why? That's again an MCQ question. We are using anticholinesterases. So I can use neostigmine, I can use pyridostigmine, I can use edrophonium, but not physostigmine. हाँ, Sugamadex तो use कर ही सकते हो ना. I'm coming to that. But out of the options given, see, this was a proper PYQ. So use the same options. Yes, we will add. Okay, I'll tell you the reason for that. Physostigmine is not used because it crosses the blood-brain barrier. Remember this. This is asked in the exam. Now, okay, so I know your doubts. Let me go to that. So therefore, the first thing asked is by Dr. Pratiksha, neostigmine. Dr. Arpit is neostigmine with glycopyrrolate. Do we add atropine to it? So normally what happens is, while giving neostigmine, acetylcholine normally goes back to the synaptic vesicle, right? What happens is, cholinesterase enzyme destroys acetylcholine, it goes back to synaptic vesicle, okay? And when we give remember it's a competitive block. We discussed vecuronium with competitive to acetylcholine. So till the time vecuronium is sitting at the receptor, acetylcholine will not do its function. So to reverse that effect, I will give neostigmine. What does neostigmine do? Neostigmine blocks acetylcholinesterase enzyme. So now the acetylcholine is not going into synaptic vesicle and it increases in the synaptic cleft. At one point, acetylcholine becomes more than that vecuronium or the non-depolarizing. That is what is called as reversal. This is called as reversal. But what is happening is that the acetylcholine concentrations are increasing not only at the nicotinic receptor where it works, it is also increasing at the muscarinic receptors. Okay, the increase in acetylcholine at the nicotinic receptor, here it leads to the reversal of muscle block. But the increase in muscarinic receptors acetylcholine would lead to side effects, which is increase in secretions, frothing, bronchospasm, bradycardia, and therefore neostigmine is never given alone. That is the reason why you add glycopyrrolate or atropine. So therefore atropine or glycopyrrolate are added to counteract the muscarinic effects of the increase in acetylcholine that is taking place. So reversal is always basically, guys, neostigmine plus glycopyrrolate or atropine. Thumbs up. Clear, everyone? Okay. हाँ, और एट्रा सिसएट्रा में नहीं चाहिए. So all the drugs that don't need reversal, so you will find atracurium and cisatracurium, they don't need reversal because of Hoffman's elimination, right? Hoffman's. Then you will get mevacurium. It gets metabolized by the same plasma cholinesterase which metabolizes succinylcholine. So therefore it needs no reversal, mevacurium, right? Then you get rocuronium. No, yes, rocuronium. It has a special reversal agent, which is a cyclodextrin. Special reversal agent which causes fast reversal, right? And that is sugamadex. For that, you don't need to give neostigmine. It's like a chelating agent. Chelating agent means what? It's a binding agent. It will come, bind, and take it away. So it needs no neostigmine. Why do you don't want to use neostigmine? Because neostigmine use is creating these muscarinic side effects. And that's why we are trying to use those drugs where you don't have to reverse giving neostigmine. And that is why atracurium and cisatracurium are so important. That's why mevacurium comes in the exam. And that's why nowadays rocuronium and sugamadex are coming. Also, sugamadex can be used for rocuronium, a little bit with vecuronium, and they say even pancuronium. All right. Now, the last point is, remember, here is gantacurium. It's a new drug under research for which the reversal agent is supposed to be L-cysteine amino acid. Okay, still under research. Ultra short acting, right? Correct, Dr. Arpit, all of you are fine. Scoline, mevacurium, atra, not in asthma. Correct, because they are causing histamine release. Correct. Doctor, all of you clear then all your options and doubts? I think I saw everything. Huh? I hope I have not missed out any questions, any doubts that you had. Second. ठीक है, so I think we are almost done. थोड़ा सा एक दो क्वेश्चन और बाकी रहेंगे, spinal and all. Okay, clear? So next question. A patient undergoing surgery is maintained on anesthesia with halothane. During the procedure, suddenly develops hyperthermia and muscle rigidity. Okay. Which ones are safe in liver disease? Okay, liver and okay. Remember, atra and cisatra. These are the ones which are used in liver patients, renal patient. Okay, daycare surgery. No, not daycare. Liver, renal, and neonates, pediatric patients, and neuromuscular disorders or nerve disorders. For a cardiac patient, right, vecuronium is preferred for a CVS patient. Any non-depolarizing is used for a patient of CNS, right? And someone having a respiratory problem, right, respiratory disorder. In that case, you will have any drug without histamine. Any drug without histamine release. Okay, clear? Cisatracurium is more safe in liver and renal. Yes, not safe, but it is much better. See, cisatracurium and atracurium, the difference is that cisatracurium is supposed to be more potent than atracurium. Cisatracurium has less levels of the metabolite, ludanosine. Okay, and atracurium has more levels of that, and this is known to cause seizure. So therefore, it has less levels of this metabolite, and also it has no histamine release, which is seen with atracurium. That's why this atracurium is much more safer. Atracurium has histamine release. Okay. Rocuronium ko to bola. Where is rocuronium preferred? Rocuronium is preferred wherever you need a special reversal, fast reversal, or for a daycare surgery. So now, if you say daycare, so nowadays what is happening is for daycare surgery, in daycare surgery, you need shortest acting. So succinylcholine, 𝐒𝐴 can be used, but even rocuronium, since Sudamadex is available, can be used. Right? What is Hoffman's elimination? Hoffman's elimination is temperature and pH mediated degradation without any enzyme. Okay, wait, what is Hoffman's? So Hoffman's is basically temperature, it's temperature and pH based without any enzyme, non-enzymatic degradation. Means you don't have to use, there's no enzyme of the body which is being used. So that's why it becomes safe in a patient of liver and kidney disorder. Okay, clear everyone? Okay, so ये renal हो गया. Next question. A patient undergoing surgery is maintained on anesthesia with halothane. During the procedure, patient suddenly develops hyperthermia and muscle rigidity. Which of the following drugs is most likely implicated in the condition? DTC and DEXA, which are more vagolytic? DEXA कैसे होगा? एक सेकेंड, जस्ट वन सेकेंड. एक क्वेश्चन था यहाँ पे, तो आंसर बी है. करेक्ट. हियर ऑल ऑफ यू आर करेक्ट. द आंसर इज बी. Right, because we are discussing malignant hyperthermia. So remember, malignant hyperthermia is basically caused by volatile anesthetic agents, especially halothane. It is caused by succinylcholine and lignocaine, right? And that is why in a patient of malignant hyperthermia, if he comes for surgery, in that case propofol is the drug of choice for GA, and because lignocaine is also avoided, so procaine is used for local anesthesia. And treatment of malignant hyperthermia in the OT is dantrolene sodium. Right, these are the questions from here. Clear? Dexamethasone is the answer. There is one question where Dr. Devaki has asked me about vagolytic. Again, so okay, let me discuss here. Vagolytic means increasing in heart rate. So all the drugs, guys, that are, see, histamine releasing drugs there, histamine releasing drugs, basically the maximum is by DTC, D-tubocurare, and then there is by atracurium. In the past, it was by rapacuronium, but it is also seen a little bit with 𝐒𝐴 and succinylcholine. Drugs that are going to increase the heart rate. So you are going to have pancuronium and galamine, the old drug, which not only increases the heart rate, they also increase the blood pressure. And the heart rate is also increased by rocuronium. Rocuronium is vagolytic. So these are the drugs which are increasing the heart rate and histamine release. Okay. Hopefully this point is also clear, Dr. Devaki. पोस्ट MIVT में लिग्नोकेन देते हैं ना? See, lignocaine is a slow sodium channel na, it is used. So whenever you want to use class 1B anti-arrhythmic agent, lignocaine का IV use यही तो होता है. Lignocaine, the IV uses are intravenous regional anesthesia, right, to decrease the pain of propofol injection, to decrease intubation response, and it is an anti-arrhythmic agent class 1B. ठीक है, class 1B anti-arrhythmic agent. The slow, according to me it is 1B, but you people would be knowing it better. But according to me it is class 1B slow sodium channel blocker. ठीक है, तो इसको वहां पे यूज किया जाता है anti-arrhythmic agent lignocaine. All right, but these are the IV drugs. See, this is the IV uses, and remember the IV means it is preservative free. The normal lignocaine has preservative, so this one is preservative free. Remember this point. This was again an exam question. No preservative. This lignocaine is preservative free. It's not the normal lignocaine. Okay, 30-year-old male patient was intubated by a final year resident. Which of the following is the best method to confirm the position of endotracheal tube? Hyperkalemia is there in hyponatremia. Sir, one more question asked about electrolyte level of sodium and potassium in malignant hyperthermia. Sodium potassium नहीं, रुक जाओ. See, there is going to be changes in the कहाँ गया? Malignant hyperthermia. So in malignant hyperthermia, it's a disorder of the ryanodine receptor. Calcium release होता है. There is increased calcium release that takes place. This causes your abnormality in the potassium. So normally it changes the calcium, potassium changes. So it increases the potassium that you see, right? It increases there is increase in potassium, increase in calcium, and all this leads to arrhythmias that is seen on the ECG, right? The increase in calcium also increases the metabolism of the patient, which leads to increased temperature production, and it increases the carbon dioxide production, because of which the patient has fever, malignant hypothermia, and CO2 can be detected by capnography. You get a graph which keeps on increasing, right? It keeps on increasing. And then there is muscle rigidity, because the muscles get involved as it is a disorder of the sarcoplasmic reticulum, and it can cause damage to the muscles leading to myoglobinuria, all right, and damage to the muscles have taken place. Clear? Correct, that's what I'm saying. Muscle rigidity, myoglobinuria, and changing the electrolytes this way. Clear, guys? All right, hopefully it's cleared your doubt. Hopefully. All right, here everyone is correct. Okay, EtCO2. The best method ideally is capnography. And guys, along with capnography, even remember fiber optic is one of the best methods, because fiber optic is nothing but direct visualization on the television. It's a direct visualization. Okay, it's a direct visualization, so this is important. डॉक्टर दिव्या की शायद रेड यूरिन नहीं होता है, मायोग्लोबिन यूरिया शुड बी ब्लैक, डार्क कलर्ड यूरिन. वो रेड भी हो सकता है बट नॉर्मली इट्स डार्क कलर्ड, आई थिंक सो. ओके, क्लियर एवरीवन? सो हियर द आंसर इज एन टाइडल CO2, EtCO2. Next question. Which maneuver is being performed in the given image? Another 2-3 questions. I should be finished off by 9, hopefully. 9 o'clock. 3 hours is what we took. Correct. It is simple head tilt, chin lift. All right. Head tilt, chin lift. Absolutely correct. Okay. A patient presented with headache, vomiting, and fever. Meningitis is suspected while performing a lumbar puncture, which is the last layer you will puncture just before entering the lumbar system. So initially you were all right. Yeah, this is head tilt chin lift maneuver during CPR. Correct. Here you're doing a lumbar puncture, right? Question like this has come last year also. Breathing circuits I'll discuss, right? LMA also have one question towards the end, right? Breathing circuit also will take a call. I'll discuss that. Almost done, don't worry. So C is the correct answer, arachnoid. Okay, it's not pia, guys, it is arachnoid. Okay, so subarachnoid, lumbar puncture is after the arachnoid. Okay, this is one image. Which of the following layer, which is the correct answer about the layers pierced? Okay, which one is correct? Which of the following is correct regarding the layers pierced? Which of the following is correct regarding the layers pierced during the following procedure? कौन सा layer procedure हो रहा है? Right, I think all of you have already given the correct answers. Skin, subacute, supraspinous, interspinous, and ligamentum flavum. Correct, all of you are absolutely right. So when you are going to give, the first layer is the skin, next is the subcutaneous tissue, supraspinous ligament, interspinous ligament, ligamentum flavum. You cross it, you come to the epidural space. Epidural means outside the dura, so the next is dura. After the dura, you're starting to get the meninges. So dura, after that you get the arachnoid, which you've studied. As soon as you puncture the arachnoid, there is a CSF. So CSF lies between which two layers? Arachnoid and pia. When you're giving spinal anesthesia, you're giving the drug inside the CSF. This is where you do the lumbar puncture. Epidural, you have given the drug here in the epidural space. Clear? So the last layer before epidural that you puncture is ligamentum flavum, and the last layer that you puncture before spinal is arachnoid. Clear? I think all of you are aware of this. This is the answer. Okay. So this we've already done. A young male patient was given a regional block with 0.25% bupivacaine for a minor surgical procedure. Shortly after that, patient is unresponsive, pulse is not recordable. Which of the following is the best Okay, here the answer is, all right, all of you have given a correct answer, intralipid. Okay, right, this I already discussed, but this question was again asked in the exam. These are common questions, Sugama Dex, intralipid, which have been asked. Now, Dr. Arpit has asked me, most common needle is dura separating. So when you speak of the types of needles, guys, there are two types of needles which we use for spinal. Okay, the epidural needle is called as the Tuhi needle. Right, this needle has 1 centimeter marking, and this needle is basically slightly curved. It has a curved tip, right? 1 centimeter marking, it is thick and it has a curved tip. So the epidural needle will look like this. It has got 1 centimeter markings, and then towards the end there is a slight curve that you get. All right, and then you have these markings over here, 1 centimeter markings. These are your epidural needle, right, to tell you how far you're from the skin. And then you can pass a catheter, so it's thick. Compared to that, the spinal needles are much more thin. There are two types that you get to see. One is this. This is called as a dura cutting needle. This one. This is your 𝐒𝐿. This leaves a bigger dural rent. It cuts the dura and leaves a bigger dural rent. So much big. This is your dura cutting. 𝐒𝐿. Right? It causes more damage to the dura, more incidence of PDPH. On the other hand, you get a needle like this, which is pencil tip. This is called dura separating. It leaves a small dural hole. This is Whittaker and Sprott. They cause less damage. Okay, so they are causing less damage to the dura. These are called pencil tip needles, dura separating or dura splitting. Clear? Okay, all of you, clear till here? Right, this was one doubt. This is also done. Next, the image given below shows neuromuscular monitoring of a patient after anesthesia. Which is the most common used nerve for monitoring? Simple question again. Welcome, welcome, Dr. Arpit. Welcome. Dr. Shivam says A. Correct. Ulnar nerve. Remember, the most common used for a neuromuscular monitor. It monitors the neuromuscular junction. It is monitoring the neuromuscular function. This is where we give the train of 4 mode. The most common mode is the train of 4. Train of 4 mode is the most common mode that is used. The most common use is the ulnar nerve, and the corresponding is the adductor pollicis muscle. This is most common, but remember, the most ideal, they say, is the facial nerve. Facial nerve corresponding, you can use the orbicularis oculi muscle. Correct. So that is regarding the neuromuscular monitor, which monitors the neuromuscular junction. The most common mode is train of 4. Most common space, the nerve that you use is the ulnar nerve and the adductor pollicis muscle. All right. So this is the most common. Clear? Okay. This in the adjoining image, the Malampatti score is, every second year one question comes on Malampatti. You know, Airway. Yes, guys. Very nice. Very nice. Most of you have given a correct answer. The answer is D. Remember, whenever they ask you Malampatti, the first thing is there should be mouth open, open mouth, extend the tongue. Tongue should be completely extended and do not phonate. नहीं करना होता है. Do not phonate. What are we supposed to see? Posterior pharyngeal structures, and for exam purposes, just remember one structure, uvula. Can you see uvula? No. Straight away Malampatti 4. So what happens in Malampatti is that if you see the complete uvula, it's Malampatti 1, right? If the uvula is seen completely, it is Malampatti 1. If the tip of the uvula is not seen, tip of the uvula is obscured, it's Malampatti 2. right? If you can see just the base of the uvula, can you see? You can just see the base of the uvula. So only if you can see the base of uvula, that's Malam Patti 3. And if you can't see the uvula at all, that is Malam Patti 4. That is only one structure can tell you base. You don't have to look at anything else. Okay, right? Only this one structure will tell you. So Malam Patti may just look at the uvula. If you can see the complete uvula, Malam Patti 1. If the tip is not visible, Malam Patti 2. If you can see the base of the uvula, Malam Patti 3. And nothing is seen, is Malam Patti 4. Right? Apart from that, what else do you see? So you also get to see this. These are called the tonsillar pillars, and this area here is called the fosses. So you get to see tonsillar pillars completely and fosses completely. Of course, soft palate and hard palate as well in Malam Patti 1. In Malam Patti 2, you will realize fosses and pillars are seen half, right? So these fosses and pillars are seen half, but soft palate, hard palate are seen. In Malam Patti 3, these two are not seen, right? So in Malam Patti 3, tonsillar pillars and fosses are not seen, but soft palate, hard palate are seen. Malam Patti 4 में कुछ नहीं दिख रहा है except for hard palate. Why is this important? They say Malam Patti correlates with the laryngoscopic grading, which is called as, this is called as the 𝐒𝐿 grading. So Malam Patti correlates. When you can see the uvula, you can see the vocal cord. When you see half uvula, you can see half vocal cord. When you don't see the uvula, you don't see the vocal cord. So it indirectly tells you about intubation during laryngoscopy. So this is why Malam Patti is important. It tells you about the ease of intubation, whether you will be able to intubate the patient or not based on OPD basis I can talk about. Okay, so Malam Patti 1 and 2 are relatively easy. Malam Patti 3 and 4 are difficult because they correspond to the laryngoscopic grading, which is called as the 𝐒𝐿 grading of ENT. Okay, Dr. Sapna says, thank you, Dr. Sapna. Okay, just one structure, बाकी देखने की जरूरत नहीं है, but that is one of the easiest thing that you can do, right? Clear? Hopefully people have gained something. Last question, I think, after this, and then I'll discuss breathing circuits also, which you had asked me. I'll discuss that also. So this was the second last one, Malam Patti, important question. You guys remember? Last one that I'll discuss as a question. Identify this device. Here I'm discussing, this question had come in the exam. So I'll be discussing these airway devices here. And after that, breathing circuits. This is the last question according to me. Okay, identify the device. Nice. Correct. All of you are absolutely correct. Okay, it is ProSeal LMA, right? Now, the same question can be changed. This device, let me change the options. Is it a first generation LMA? Is it a second generation LMA? Is it a third generation LMA? Or it's a fourth generation LMA? INI-CET question. Identify the device. Is it a first generation LMA? Same options A, B, C, D. Correct. This becomes your now a second generation LMA. Remember, the difference between first and second generation is depending on the presence of a drain tube. All the first generation is going to have only one tube, which is the airway tube, which is your classic LMA. So if you look at this one, the first one over here, it has got only one tube. This is your classic LMA. But here you get two tubes. This is what is your ProSeal. So this classic LMA was first generation. This becomes second generation. The second tube is for the Ryle's tube or the nasogastric tube that can be passed inside, orogastric that can go inside the stomach. The problem was the classic LMA IPPV is contraindicated because it is going to cause, just like bag mask ventilation, it is going to cause gastric distension. If you give it for IPPV, it is going to cause gastric distension. So now if you put a Ryle's tube, the gastric distension is taken care of. So therefore the ProSeal helps you to decrease, not prevent, the second generation devices help you to decrease the chances of aspiration. Here in first generation, there are high chances of aspiration. But second generation will have decreased chances. The next device that you see is what is called as iGel. This is basically a cuff-less LMA, no cuff. But it has two tubes. One is here and the second tube is here. From here you can pass a drain tube that goes inside the stomach, right? So when you speak of the laryngeal mask airway, guys, so laryngeal mask airways are classified into two types, one tube and two tube. Okay, LMAs are of two types. One containing one tube, other containing two tubes. The one tubes one are the one only with the airway tube. They are the classic LMA, the intubating LMA, flexible LMA, and unique LMA. In fact, most of the AMBU LMAs, and this was one question asked last year in INI-CET, AMBU or 40. Most of the AMBU LMAs are first generation. But second generation, the ones which have a drain tube also. Second tube means drain tube also, where you can put a Riles tube in the stomach. This advantage is these can be used for IPPV. You have the ProSeal LMA, Supreme LMA, iGel, the cuffless LMA, and out of all the AMBU devices, there is AMBU Aura Gain. This is your second generation, right? Remember, the second generations can be used for IPPV. Drain tube is also there, so less chances of aspiration. So IPPV can be used. All right, this is okay, everyone. So this is about that. And the next devices that you see, this is what is called as a oropharyngeal airway. This one is a nasopharyngeal airway. This was asked last year in NEET PG. Okay, remember, a lot of people confused it with a uncuffed endotracheal tube. This is not uncuffed. If you will have an endotracheal tube, in endotracheal tube, we are going to get a Murphy's eye. A Murphy's eye is an additional port for ventilation. In an endotracheal tube, you are going to get a vocal cord guide. The vocal cord guide tells you where to place it on the vocal cord. Apart from that, you will have these numbers written over here, which are the depth markers. That is missing. The depth marker tells you where exactly to place it on the lip. And then there is the radio opaque line which goes on the back, which is seen on the X-ray. So in a nasopharyngeal airway, there is no that blue radiological radio opaque line. That is not there. Plus at the end, you're not even going to get a connector on this part, right? So it is not an uncuffed tube. This is a nasopharyngeal airway, right? Now both these devices, oropharyngeal and nasopharyngeal, they prevent the backfall of tongue. Point is that this is contraindicated in an awake patient. If you use it in an awake patient, it will stimulate the gag reflex, lead to laryngospasm, vomiting, and aspiration, right? If you use it in awake patient, it will cause gag reflex. But nasopharyngeal goes from the back of the nose. So therefore, the biggest advantage is that I can use it in awake patient. It prevents the backfall of tongue, the same thing. But because it is going from the nose, it bypasses the gag reflex. It can be used for awake patient. But the contraindication are all like nasal endotracheal tube. The contraindications are basically fracture base of skull, CSF rhinorrhea, all right, fracture to the face, and anything which is nasopharyngeal or nasal pathology, any nasal, nasopharyngeal or retropharyngeal pathology, adenoma, polyp, bleeding, right? All these are contraindications to nasal tube. Are there any third generation? Third generation अब आ गया है. Fourth generation तो नहीं है. Third generation, a lot of people say a new device called Basca tube. You people don't need to know it, but the third generation, they say Basca tube is kind of a third generation LMA. Fourth generation अभी तक नहीं है. Clear, Dr. Pratiksha? Which is single use. Okay, correct. Good point. This कहाँ गया अपना? Where did we discuss that? LMA, हाँ. So what is happening is that intubating LMA and Supreme, they both are used for difficult intubation, difficult airway patients basically, right? Flexible LMA has that spiral metal wire, just like a flexometallic tube. This has that metal wire inside. That is why it's called flexible. Unique LMA is what is single use. In fact, this is Supreme is also single use, but it is used for difficult airway, right? and flexible is that what is having the wire inside. I-gel is basically the cuffless LMA. Okay, right, ये अपना हो गया airway, oropharyngeal हो गया covered, nasopharyngeal हो गया covered, right? Then you have Dr. Gayatri has asked me north and south RAE tube indication. Okay, so when you discuss the types of endotracheal tube, so ring Adair Elvin, इसका full form भी पूछा है exam में, they've asked you this as well. Ring Adair Elvin tube, which is called RAE tube. These are preformed tubes. Preformed means they have a preformed curve. So normally what will happen is this tube will either face, the connector will face the leg of the patient, or the connector will face the head of the patient, right? It is going to be like this. So when the connector faces, if this connector faces the leg of the patient, it is called south pole. If the connector faces the head of the patient, it is called north pole. Now, north pole can be used for any oral maxillofacial surgery. South pole is normally preferred when you're operating cleft lip, when the upper part of the palate is when you're operating. So cleft lip and cleft palate is where you prefer to use. Other surgeries also, but commonly used is for cleft lip and palate. Right? Okay. Can we use airway in seizure? Yes. For seizure patient, you're going to use the oropharyngeal airway. It has this bite block. It prevents the biting of the tongue. Okay, seizure patient. So oropharyngeal airway can be also be used during convulsions. It prevents the biting of the tongue. Okay, Dr. G Raya, sorry. Okay, and I think I finished all these questions. North and south RAE tube, clear everyone? ये भी हो गया. Okay, circuits. Okay, I'll discuss circuits as the last part because I think this was the last question that I had. So circuits we'll discuss. You wanted to know. So breathing circuits, guys, are classified into three types. Open, completely open, which is like the old open drop method, not used anymore. Semi-closed or semi-open, at your level both are the same. These are the Mapleson circuits. And the closed circuits which contain soda lime, which is also called as the circle system. So closed circuit, remember, closed circuit is the one that contains soda lime. Right? It absorbs carbon dioxide. Therefore, rebreathing takes place with removal of carbon dioxide. Scavenging is possible, right? And it is called a circle system. These are your closed circuits. Talking about the circuits, Mapleson one. So these semi-open or semi-closed at your level are the Mapleson circuits. Mapleson circuits are formed by 5 things: fresh gas flow, bag, tube, adjustable pressure limiting valve, which is called as the expiratory valve, and the mask. These are the 5 things that make a Mapleson circuit. 5 things. Okay. So when you speak of Mapleson circuits, they are of 6 types. But you guys need to remember only 3. A, B, C, D, E, and F. Mapleson A is your McGill circuit or LAC circuit. Remember, it is used for a spontaneously breathing adult. Mapleson B is kind of obsolete, they won't ask you. Mapleson C is again obsolete, they won't ask you. But remember, a modification of Mapleson C nowadays is used for that chest physiotherapy and CPR. Mapleson D is called Bain circuit. This is used for a IPPV or controlled ventilation in adult? So remember, for adults, D and A are the only two circuits that they'll ask you, because B and C is obsolete. Okay, they won't ask you, right? So A and D is what you need to know. Mapleson E and F are both used in children. So Mapleson E is called as a Ayers T-piece. It was made for a neonate. There was no bag and no valve. It was made for a neonate, but it is not used so often in them. Also, it is used in ICU patients to wean a patient off ventilator. These are two uses. But the best circuit that is used for pediatric patient is the F, which is Jackson-Rees circuit. Remember, Jackson-Rees as JR. JR means junior. It is used for pediatric patient. Pediatric patient less than 6 years of age, less than 20 kg. If more, the answer is Bain circuit. So you guys need to remember just 3 circuits from here. Okay, and those 3 circuits are A, D and F. So remember, A and D are both used in adults, right? Mapleson F is what is used in pediatrics. Clear, everyone? These are the normal questions which come. All right. Right. So this is our Sankalp batch going on. Predictor GTs are live. You can attempt. As I said, this was the last question, right? You can have my Telegram ID and Insta ID. My Insta ID is Dr. Vinish. You can follow me. Insta ID dr.vinish. I'm the one with the guitar, playing guitar over there. No one sees my MCQ questions. All of you just see the guitar. Dr. Arpit, thank you so much. Dr. Shivam, thank you so much. Dr. Pratiksha says, sir, please explain TOF a little. Okay. Marathon तो अभी NEET PG का marathon अभी आ रहा है. It's coming. Marathon is going to come. I think by 17th, around 17th, 15 to 17th. I think just follow here. 15 to 17th के आसपास है. Dr. Sapna, thank you. Dr. Pratiksha, thank you. Dr. Gayatri, Dr. Lagnajit. Dr. Lagnajit, you gave 2 wonderful quotes. Thank you so much. Okay, and thank you all of you for the wonderful comments that you people have given. Thank you, Dr. Parul. Thank you. Okay, now let me discuss TOF. Any other question also I'll try to discuss. Okay, so TOF को discuss कर लेते हैं. Train of 4. So train of 4, guys, remember 4 stimuli are given. So basically what it is telling about the neuromuscular junction. So if you are giving 4 stimuli, each stimulus is basically of 2 hertz. Now, all of you, do you remember what is the meaning of this stimulus? All of you remember in first prof, there was something called as a physiology lab, which you have forgotten now. Remember? Anatomy, everyone remembers, dissection hall. But there was something called as a physio lab also. If you remember, there was a biochem lab as well. In the physio lab, there used to be experiments of physiology that we were doing. In that physiology experiment, there was EMG also. You have to see the response of a muscle to various stimuli, where you were studying in the physio lab single twitch, double burst, train of 4, tetany and post tetany, right? This is all what was seen in that prop. The same out of what that you studied in first year physio is what is used here clinically, right? So this is the train of 4. Each stimulus is of 2 hertz. It is given in a span of 2 seconds, right? And every stimulus is at 0.5 seconds. Every stimulus is at 0.5 seconds. If there is no paralysis, your for example, ulnar nerve, I stimulate 1, 2, 3, 4. I stimulate 4 times, 1, 2, 3 and 4. So what happens is the electrical circuit will pass like this through the finger, and here it will cause movement of the adductor pollicis. So I'll get 4 response of the same height, 1, 2, 3, right? But in case if it is blocked, so in a normal response is going to be of the same height. But in case if it is blocked, not all the receptors are occupied, right? So in that case, when it is blocked, right, and not all the receptors are occupied, in that case, you may get some responses, right? You might get some responses. So if the block, some receptors are free and some receptors are occupied. So in this case, if the block is with a non-depolarizing muscle relaxant, the first stimulus will be slightly like this, second will be little smaller, third is going to be smaller than that, and fourth is to be smaller than that. This is what is called as fade. So a non-depolarizing, you get to see fade where the fourth is least compared to the first one. Okay. Now with depolarizing, which is succinylcholine. So succinylcholine, what happens is, again, some receptors are occupied and some are free. So in this case with succinylcholine, the way it works is that you don't have to go into details, but it will become of the same height, right? So what happens is the amplitude has become less, but the height remains the same. Same height and decrease amplitude. Correct. But remember guys, succinylcholine has two types of blocks. Normally succinylcholine gets destroyed by plasma cholinesterase, right? So this is what is called as succinylcholine normal paralysis phase 1 block. But in case of a plasma cholinesterase deficiency or someone having atypical plasma cholinesterase or someone having got a lot of doses of succinylcholine, in that case the person does not have plasma cholinesterase to destroy succinylcholine. I had discussed with you that succinylcholine is duration of action is only 5 to 8 minutes. Why it was 5 to 8 minutes? Because it was immediately destroyed by plasma cholinesterase. Remember I discussed this with you, 5 to 8 minutes. But in case of a plasma cholinesterase deficiency, it is not going to get destroyed. So now because it does not get destroyed, who will destroy succinylcholine? Because plasma cholinesterase was there in the plasma. If someone's plasma does not have the cholinesterase, succinylcholine does not get destroyed. Instead of 5 to 8 minutes, this block becomes 5 to 8 hours. This is what is called as succinylcholine phase 2 block. It is also called, I mean, similar to that, I'll not say the same thing, but you know, there are slight differences. They are all called as dual block also. You also call it succinylcholine apnea because instead of 5 to 8 minutes, that will cause 5 to 8 hours of block. The only treatment ideally for that condition is IPPV, nothing else. But there's a point. When succinylcholine becomes phase 2 block, in this case, it resembles non-depolarizing block. It resembles and shows the features of non-depolarizing block. So therefore, what was the feature of non-depolarizing block? Fade. So therefore, because it goes into phase 2, now it tries to show you the same fade. And this is the exam question. Succinylcholine in phase 2 shows you fade. This helps you to differentiate the types of block. Clear everyone? Okay. Yes, Dr. Shivam, Debbucane number is when you're using, you know, the Debbucane to find out a presence of homozygous or heterozygous, you know, in case of an atypical plasma cholinesterase. You don't have to go so much into details. All right. But this much is important. And as Dr. Shivam has said, correct, Debbucane number is just to identify the presence of which kind of gene or deficiency is there. You know, if it's a genetic problem, so what kind of deficiency is there? So correct, that's the reason why you use the Debbucane number also, but don't go into too much details of that. Okay, that's Debbucane number. Clear everyone? Dr. Pratiksha? Fine, thank you. Any other questions or doubts, guys? I tried to solve to the best of my knowledge. So that's my Insta ID, Dr.Vinish. Okay. Telegram ID, you can message me directly on Telegram also. So Telegram is what? My Telegram is Doctor without the dot Vinish. Again, both of them will have an image with a guitar. Okay. So thank you guys. Any other questions and doubts, let me know. Otherwise, all of you have been wonderful. All the best. Do well. Want all of you to succeed and score a good rank. And let us know when you score it. We feel good about it. Okay. We feel as if we have cleared the exam. We have got a seat. We have scored the result. Okay. So do share your results with us. We'd love that. Any questions or doubts? Otherwise, thank you for joining me at this session. I know it was a long one, but thank you everyone for joining. Okay. And wait for the marathon. We are coming with the marathon as well. Okay. So fine, guys. Bye-bye. Good night. All the best and take care. Bye. Thank you, Dr. Pratiksha. those comments, all of you, the way everyone has commented, and this is what makes our day. Thank you so much. Okay, so study well, all the best. Okay, otherwise all of us are there, and don't worry, be confident, score well in the exam. Okay, anesthesia is an easy subject, don't worry. Okay, chalo, bye bye, good night. Follow me on Insta, and you can message me on Telegram directly. I'll try to answer your doubts. Dr. Aki, thank you everyone. Okay, good night.